Michael Blair. Please give him a round of applause.
Hello, good morning. Oh, it's afternoon. Sorry, my bad. Just eating breakfast, that's why. Good afternoon, everyone. I hope everybody is well fed and everybody having a great time so far. I must say that this is a historical moment for the NPAJ in association with UWI. As a sporting body, we are hosting our first medical workshop. The association that started only 5 years ago. I must say thanks to Dr. Burke, who have done a tremendous job on our team to put this together. I'm just the one who sits around the back watching, so I've done no hard work. But when you're president, that is what happens. You get all the praises for all the hard work other people does. Okay, so first I would like to say welcome to everyone. It's a great pleasure for you to find the time to register for our first medical workshop, and I hope this will be an exciting moment for you. I hope that every time going forward, we put on other workshop that you actually become a member of our association in terms of participation. I don't want to keep much of your time, so thank you very much and have a great day.
Preparing for my track and field debut. I'm going to ask Father Richard Brown, who is the pastor for Stella Maris, to just come and bless the proceedings for us before we go any further. Father Brown.
We bow our heads as we pray. God of light and love, we gather to give thanks, especially today as we celebrate National Day of Thanksgiving, giving gratitude to God for all that He has done for us. And today as we gather as medical person vested interest in development of our people. And as you come for this seminar workshop, pray that God's will be done in your lives, that this work that has begun may continue to bear fruit, not just today, but for onwards. We pray that God's Spirit will over all of us, keeping us safe. May have a productive day, productive events, that as we leave here, the work continues, the journey continues in building God's kingdom. We ask this through Christ our Lord. Amen.
Thank you, Father Brown. So again, I would like to say welcome to the persons here, especially the persons who are online. I don't have it's not in front of me how many persons are online, but we welcome you and we thank you for attending. So in the interest of time, in maximizing time, we are going to switch around some of the order of the speakers so that those persons who are physically here will be able to carry on their presentations. Our first moderator, or moderator for the morning session, is Dr. Diallo Rudolph Brown. He's a sports physical therapist and a certified strength and conditioning specialist at the UWI Mona Sports Medicine Clinic in the Faculty of Sports. He's also a member of the NPAJ's medical committee and also a member of the Jamaica Association of Sports Medicine. Please join me in welcoming him, Dr. Brown, as our first moderator.
All right, hi, good afternoon, everyone. Good afternoon, friends and colleagues in sports medicine and in sport. Welcome. Special welcome to my fellow members of the Jamaica Association of Sports Medicine. Good to see you guys. All right, so as mentioned, I'm Dr. Diallo Brown. I'll be moderating the first session. In this session, we'll have 4 presenters, and I'll introduce them in turn. We're going to start with our second presenter first, so to speak. I'll introduce him. Just to make a quick mention of our sponsors, Suppligent, a long-time loyal sponsor of the NPAJ, DT Physiotherapy Limited. You'll hear from the CEO and owner later on today. He's one of our presenters. Also, Indus Pharma private company. They are in pharmaceuticals and health. One of our lawyers, one of our main sponsors, and also the Sports Development Foundation. All right. So, without further ado, okay. Our first presenter will be Dr. Andre Bateman. He's a clinical psychologist, and I guess you could say a sports psychologist. He's a lecturer in clinical psychology at the University of the West Indies, and he specializes in the psychosocial aspects of sport and physical activity. He has a Master of Science in Clinical Psychology and Doctor of Philosophy in the psychosocial aspects of sport and physical activity. His research focuses on athlete mental health, motivation, and resilience. And Dr. Bateman is also a member of the NPAJ Medical Committee, as I am. Now, Dr. Bateman will present today on mental skills in athletes. His presentation, I believe, is virtual. So we'll go ahead with that first presentation. Dr. Bateman, we have you online?
Yes, I'm here.
All right, thank you, Dr. Bateman. Go right ahead.
Hi, good afternoon, everyone. I just need confirmation that we're seeing my screen.
All right, it's coming up. Yes, you're seeing a screen.
Okay.
Right, yeah, man, ready to go.
All right, thank you. Thanks, Diola, for the introduction. So I'll be presenting on the role of sports psychology in the holistic functioning of the modern athlete. And this is the order of my presentation. So I'll be doing a quick introduction, and then I'll be sharing some research findings, talking about stressors in sport, talking about the role of a sports psychologist, introducing the practice of sports psychology, talk a little bit about building confidence. Then I'll introduce a practice case, and I'll allow for questions, and then there'll be a post-test quiz. The way how I've organized the presentation is that I will be going through the slides fairly quickly because I believe it might be most helpful to allow time for questions. But if you have questions while I'm going through the slides, please make a note of it. I'll be happy to go back. So on this first slide, I have the fundamental problem in sport, and that is the other team or player also wants to win. And I think this quote is important because it emphasizes the need for athletes to maximize on any advantage they can get in terms of performance. And it suggests that athletes need to optimize on any area of functioning that they can, which emphasizes the mental function and how important it is for performance. And this will be supported by what I'll be presenting in the presentation. So just to give an idea of the importance of mental health or attention to mental health in athletes globally, about 35% of elite athletes have mental health concerns, with the top concerns being burnout, depression, and anxiety. Eating disorders are common in female athletes, and in collegiate athletes, about 10 to 25% have depression or eating disorders. Importantly, though, mental health cannot really be separated from physical health. Both are important and both are connected and reciprocally affect each other, where mental health symptoms and disorders can increase the risk of physical injury and definitely delay recovery and rehabilitation from physical injury. Very importantly, there has been new emerging research in Jamaican athletes, and a conservative estimate is that approximately 10% of Jamaican athletes may meet the diagnostic criteria for major depressive disorder. And this is research that I have been involved in. And to continue to explain some of the findings that we have uncovered from our local athletes, we have found that low depression symptoms, high self-esteem, high sport confidence, and high self-efficacy are associated with higher subjective performance evaluations. Continuing, in the sample of competitive athletes, the mean depression scores were within the mild range, which is what we would expect. But importantly, approximately 15% had depression symptoms in the severe range, which is why I said that 10% may be a conservative estimate. And what we found is that low self-esteem, low sport confidence, low sport self-efficacy, and low subjective sport performance is associated with higher depression symptoms. As it relates to physical injury in the same sample of competitive athletes, 33% of the athletes sampled reported that they were injured at the time of the study. And we found that injury status was associated with low sport self-efficacy and low subjective sport performance. You'll notice that on some of these slides, some of the points are in bold, and this is because these were the most important findings and had the greatest effect. So moving on, we can make 4 conclusions or claims from this study. One is that poor mental health is associated with reduced performance. Second, poor sport-specific mental skills such as confidence is associated with reduced performance. And we'll be talking about the importance of confidence a little bit later in the presentation. Third, poor mental health is associated with reduced sport-specific mental skills like confidence. And fourth and finally, injured athletes have reduced performance and reduced sport-specific mental skills. And this can be summarized in the following equation, that it seems as if in our own local competitive athletes that improve mental health and improve sport-specific mental skills functioning is indeed associated with increased sport performance, which is exactly what we want. So I like to think that even though we focus on athletes as being competitors and performance, it is important to recognize that athletes are also humans first. So athletes have to deal with life events such as having bills to pay, having dependents to support, having relationships to maintain, and so on, just like the rest of us. So in essence, athletes are really just high-performing humans. However, to function optimally, athletes are required to both manage life-related stressors, but also sport-related stressors. So their life can be a lot more complex than the average human. So I like to use the analogy of golf to explain how sports are stressful and how sports were designed to be stressful. Because if you think about a golf course, the idea of playing golf is to get the ball from the tee into the hole. But there are many obstacles along the way, and these obstacles could be stressors. So I like to use golf as a model for sport in general. And some of these stressors or challenges or obstacles in golf are the distance to the hole, the wind, the rough, the trees, the sand, the water. All of these things are obstacles. And in the same way, athletes have to face these different forms of stressors in order to maximize on their performance. So because sports were designed to be stressful, athletes have to compete against other athletes. They have to compete against themselves because they want to perform better each time. Athletes are competing against the environment, depending on the sport. That could be the weather environment, it could be other things. Athletes are competing despite sport-related adversity, such as injury. Athletes are performing for their teams. They're also performing for other people, such as fans, family, and so on. And importantly, it is the athlete who is best at managing all of these stressors who is most likely to be successful, not just at sport, but also in life. So what does a sports psychologist do? And I'm going to read this directly from the slide. So mainly, a sports psychologist helps performers to improve their performance by developing their performance or sport-specific mental skills. So notice the words in bold. In the same way that coaches help performers improve their technical skills and teaches them tactical skills, and a fitness coach has to develop their physical skills, a sports psychologist is interested in helping a performer to reach their potential by improving the mental side of their performance. So in terms of athlete psychological well-being, so athletes also experience unique stressors that may affect their psychological well-being, such as injury, loneliness, especially when athletes have to travel, for example, lack of social support, extreme pressure to perform both internally and externally, and periods of poor form. These stressors may lead to burnout, depressive states, anxiety disorders, and even stressor disorders. A clinical sports psychologist, so I label myself as a clinical and sports psychologist. And we function by supporting not just the mental aspects of performance, but also the psychological well-being of athletes. And this can be by providing psychoeducational interventions, providing psychotherapy or counseling, providing group therapy for sports groups or teams, assessing psychological functioning, and even referring athletes for medical psychiatric treatment if necessary. So here we've come to the mind and body synergy part of the presentation. So why is sports psychology important? So successful performance in sport involves 4 main skill domains. And these are physical, which has to do with things like strength, speed, agility. Technical skills like passing, shooting, playing, the different technical positioning in powerlifting, for example. Tactical, such as movement, positioning, knowledge of strategy. Mental skills also, confidence, motivation, focus, emotional regulation, and so on. But if you notice, the first 2 skills are body-related skills. The second 2 skills are cognitive skills with mental skills. So the first 2 skills are body, and the second 2 skills are mostly mind. But all 4 skills are, I believe, necessary for optimal functioning and performance in athletes. So quick quiz. And I mean, it's online, so it's not as easy to interact with the crowd. But I just want you to think about this. What is the most important skill for successful performance in sport? Is it mental? Is it physical? Is it technical? Is it technical? Or does it depend on something else? All right. So just think about that a little bit. But here's my partial answer. Mental skills are probably not the most important skill for success in sport. But I fundamentally believe that mental skill is the driver of all the other skills, such as motivation to improve technical skills. Because if an athlete isn't motivated to improve the other skills, then the other skills might become deficits, and then that athlete will be at a disadvantage. So optimizing mental skills will give the athletes an edge. And remember, competitive athletes need every edge that they can get. Remember, and that's also because the other athlete or the other team also wants to win. So if you want to win, you need every advantage that you can get. Mental skills are important at different stages of preparation and participation in sport, such as just before performance or during performance. I fundamentally also believe that successful athletes naturally have superior mental skills. And this is something that I think gets overlooked a lot. So for example, if we use Usain Bolt, I believe that one of the reasons why he was so successful, it's not just because of his natural skill, which I agree is probably off the charts, but I do believe that Usain Bolt, whether he knows it or not, has superior or had superior mental skills while he was competing. And that definitely gave him an edge. So one of my mentors, Jack Lessick, proposed the 9 mental skills of successful athletes. And this is a model that I have used and adjusted in my own practice. So he mentioned that there are, by observing successful athletes, he came up with 9 mental skills for successful athletes. And he organized them into 3 different levels. So there are basic mental skills, preparatory mental skills, and performance mental skills. So the basic mental skills, or level 1, are skills for long-term development. And these are needed on a day-to-day basis. And one could argue that they're the most important, even though they tend to be a little bit more removed from the actual performance. And these skills include things like motivation, an athlete's attitude towards a sport, an athlete's values, goals, and commitment, and so on. The preparatory level, or level 2, is a transition between non-performance and performance. And these skills are needed just before an athlete competes. And these skills are important for immediate preparation just before competition. And these skills include thought management, or self-talk, and mental imagery. And then finally, performance skills, which are required during performance. And this includes managing emotions and anxiety, and the ability to concentrate and focus. So how does a sports psychology operate their practice? And one of the things that Jack Lessick, one of my mentors who I just introduced on the previous slide, taught me is that a competent practitioner always assesses before they provide an intervention. And it's not just about throwing tools or throwing techniques at athletes. So we start with a complete clinical interview, assess athletes' mental functioning, assess their sport-specific skills, mental skills, identify strengths and areas for improvement from these assessments, and then from the results of these assessments, develop a treatment plan to improve functioning, and then execute the treatment plan. Okay, I just realized that my video was off. I thought it was on the whole time. I'm sorry. So moving on. So some of my observations of Jamaican athletes or our own sport culture. So many athletes may believe that sport is not a career. They may also believe that talent is enough to get them through sports. They may not work hard enough at getting better at their sport. They struggle with less resources and inferior facilities, which most of us are aware of. They may have good physical and technical coaching, but lack coaching in the other skills, such as tactical and mental skills. They're left to figure out the necessary aspects of sport, such as nutrition, on their own. And I somehow believe, and I'm curious to see if others agree with me, that many of our athletes do not function at their best when it matters the most. And I've seen many examples of this, for example, in athletics, especially at major championships. Many of our athletes who are expected to do well, they tend to not do as well and may even underperform in major championships. So just to talk about, very briefly, confidence and self-efficacy in sport. So if you remember some of the research findings that I introduced at the beginning of the presentation, if you notice, confidence and self-efficacy were almost always associated with optimal outcomes, such as mental health and performance. Confidence and self-efficacy are two related constructs in psychology, and they both have to do with one's belief in their ability to be successful or to perform optimally in a chosen area. So one of the interventions I use when I assess an athlete and recognize that confidence is low is this rule 1 of confidence. And the rule simply states that the acts of confidence come first, but the feelings of confidence come after. And some important things about confidence are: 1, confidence is probably the best predictor of performance. Consecutive successes may be the best predictor of confidence, sorry. Anxiety and nervousness appears to be the opposite of confidence. Also, anxiety and nervousness is associated with corresponding cognitions, or the way we think, and those anxious and nervous thoughts can erode our confidence. Also, deficits in confidence almost always compromise performance. So, how do we get athletes to improve their confidence? One way is to break performance goals into smaller task goals, then working on each of these task goals one at a time, starting with the easiest. A common mistake that athletes and performers in general make is that they keep focusing on a final outcome. I want to win at the World Championships. But instead of breaking that goal down into smaller pieces and work on being successful at each smaller piece. Because if you break it down into smaller pieces, each piece becomes easier to achieve. And when you're successful in each smaller piece, that builds your confidence as you move on and it gets more difficult. It's important also to reflect on each time one is successful and one fails, because the reflection allows us to pay attention to our thoughts and feelings. And then upon evaluating these thoughts and feelings, we can develop skills to manage these thoughts and feelings so that they can be framed in such a way or used in a way that can help to improve performance. So finally, like I said, monitor the thoughts and feelings, develop thoughts and feelings management skills, and practice these skills as the athlete trains and practice. So that brings to the end the major part of the presentation. And now I have a practice case that we can discuss, and I'll just read the case very quickly. So Abigail, a Jamaican powerlifter, was injured 2 months before a major world championship. She was devastated by this injury and thought that she would not be able to compete at the championship. However, her excellent medical team was able to get her back to full functioning in just 2 weeks because the injury was not as severe as expected. Abigail, since returning to training, has appeared moody, sad, and much less motivated than usual. Her performance in training were also not close to her best before the injury. Her coach heard her saying that she doesn't feel confident in herself anymore. He immediately sent her to a clinical sports psychologist 4 weeks before the championship. So how should the sports psychologist practitioner handle the case of Abigail? So this is open for discussion now, and also the floor is also open for anybody who has questions for me based on the rest of the presentation. So Diallo, I'm not sure how we're doing this part of the presentation workshop. So you can advise.
We have a mic I'm going to pass around.
Okay.
So any questions? Or I could pose the first question maybe.
Okay.
All right. Well, based on what you're discussing there, my fundamental question, which I think most of us in sports medicine always ask, why is sports psychology not being utilized more locally?
That's a very good question. I wish I had the answer completely to that question. One of the things I've noticed though is that from an athlete perspective, I think many athletes are very protective of sport as their craft and are a little bit unwilling at a baseline to introduce other professionals into that sacred space. And I think that that has been a stumbling block, because even some athletes that I do work with, I find that they tend to be a bit guarded, especially in the beginning, about their sport. And it takes a little while for them to get into being accepting of another professional, especially one who is so intricately tied to their own like personal space and thoughts and feelings about the sport.
Okay, and do you think there's a cultural aspect as well in terms of us not wanting to, talk about our business, especially with somebody else like that?
Absolutely. I think Jamaicans, most of us, we grew up with being very private people. And like I shared on one of the previous slides, I think one of my observations of Jamaican athletes from our sporting culture is that we grew up thinking that sport is not really a career necessarily. And because of that, I think sometimes there's a deterrent. It like many athletes are not willing to fully invest in it and to invest in the services of sports psychologists, nutritionists, and so on, who may be able to give them an additional advantage when it comes to performance. And definitely the whole idea of like stigmatizing mental health and anything psychology also plays a role.
All right, Dr. Mayman, we have one question online.
Okay.
All right. So, question from Ms. Karen Pastor. Is it
Mm-hmm.
appropriate to refer teenage athletes to a sports psychologist? Should they wait until they commit to a career? Interesting.
So I believe that, so this is like one of my fundamental beliefs. So I believe that any form of psychological intervention can help anybody at any stage of their development. It's just that I don't think that everybody might need it in the same way. So my short answer to that question is yes. I think that that teenage athlete can be helped by a sports psychologist. There are many sports psychologist professionals who believe, including myself, that believe that that is the primary age when they should see sports psychologists and mental health professionals in order to lay that foundation before they become a professional athlete. And I've worked with several most of the athletes, Jamaican athletes I've worked with are actually junior teenage athletes when they were introduced to me at the first time. And I think the intervention at that stage of their development has been incredibly helpful.
All right, thank you. I think, yes, there's a question right here. One second.
Hi, good afternoon.
Good
Is
afternoon.
I'm Dr. Lawrence. Just a quick question, sports medicine physician. Just a quick question. What do you think, or how would you then approach knowing our cultural limitations, etc.? How would you then approach associations, persons, athletes in terms of trying to get more of what you do out there and trying to get us, I guess, get more buy-in in the entire industry of sports medicine to get, to get your services and your capabilities out there? Because I, totally believe that it is inherent and it is required at all levels of sport, here and everywhere else. Thank you.
Yeah, so I completely agree with you, and I think this is one of the areas that Jamaican sport is lagging behind the rest of the world because many athletes in many other cultures are seeking these services. And if you pay attention to athletes nowadays, you'll see athletes in between events, like making notes in a journal or doing rituals and so on. And many of these are interventions that may have been developed between them and a sports psychologist. But to answer your primary question, so the challenge is, so I do agree that there needs to be more advocacy and awareness of sports psychology and the importance of it and how it can be used as a tool to improve the performance of local athletes. However, unfortunately, and I mean, I hate to say this, but like not everybody is an advocate. So I see myself as a practitioner, not necessarily an advocate, but the field definitely needs advocacy. I am willing to make myself available, especially like in forums like these, to help to increase awareness and advocate for the sport, for sports psychology. However, I don't really brand myself as an advocate and I don't have the time to dedicate to advocacy because I am busy in practice. So we do need more advocates and we do need more awareness, and I'm willing to support that. But I don't necessarily see myself as being at the forefront of advocacy in the field.
All right, Dr. Bayman, thank you very much for that first session.
Yes,
And
thank you. My pleasure.
so you say you're not an advocate. I would take it that you're a researcher.
Yes, so I'm a researcher. So my primary area is in research and practice, both physical activity and sport psychology.
All right, we'll talk.
Yes.
All right,
All
thank you.
right.
All right, so we're gonna go on to our next speaker, and yeah, so next speaker. So our next speaker is Ms. Yannick Dunn. She's the acting technical director, sorry, acting director of technical services at the Jamaica Anti-Doping Commission, JALCO. She's gonna speak on the doping control process. So she's gonna give an overview of the doping control process that's used to promote fair play and integrity in sports. She's going to outline key stages of the doping control process, including notification, sample collection, lab analysis, and results management. And of course, to speak to what happens in the case of an anti-doping rule violation or sanction. So without further ado, let's welcome Ms. Yannick Dunn. Thank you.
Good afternoon, everyone. All right, so I know most of you in here will think of doping as primarily the presence of a prohibited substance in their blood or urine of an athlete, right? However, doping is more than that. It is the violation of one or more of the 11 anti-doping rule violations. Before we move any further, I'd like to speak about the inadvertent doping or the strict liability principle. So that basically is what the athlete is responsible for any prohibited substance found in their blood or urine at any time, whether or not they know how it got in their bodies. So the first anti-doping rule violation is the presence of the banned substance in the blood or urine or the metabolites in the athlete sample. So this applies strictly to the athlete only. And this is because that's the only sample that we collect, not from the support personnel. So what will happen is that if an athlete is caught with a positive blood sample or urine sample, they will be sanctioned for a maximum of 4 years. And that 4 years reprimand, they will not be able to compete, they will not be able to participate in any sport. We also have the use or attempted use, evading, refusing, or failure to comply with sample collection personnel. So if that happens and the athletes are caught and sanctioned by the independent anti-doping disciplinary panel, they will not be able to compete. We have the fourth anti-doping rule violation, which is tampering or attempted to tamper with the doping control process. This applies to athletes and their support personnel. So that could include coaches, doctors, or anybody who is supporting the athlete. So in this case, the support personnel, in addition, can be sanctioned for a ban. Also, we have the possession of a banned substance or method. So you can find a list of the banned substance or method in our prohibited list. It comes out every year and comes into effect on the 1st of January of the year. So if you, the support personnel, is found with any of those banned substances, you can also be sanctioned. We have trafficking, distribution of the banned substance, or administration of the banned substance. The athlete, as well as the support personnel, can be sanctioned to a minimum of 4 years to lifetime. So that means the support personnel would not be able to participate in any capacity as that. So they would be sanctioned again by the independent anti-doping disciplinary panel that is separate and apart from JADCO. We have also whereabouts filing or mistests. So if we go to the athlete's location that they have selected and they are not there within a 3 month, consecutive periods in a 12-month period, they can be sanctioned, or if they fail to submit their whereabouts, that's where we can find them to test. They can also be sanctioned for that. You have complicity or attempted complicity. That's simply covering up for the anti-doping rule violation. The athletes and the support personnel, that's you, the coaches, or anybody in that capacity, or medical doctors, can be sanctioned for a minimum of 2 years to lifetime. You have prohibited association or the acts by a person or athlete to discourage reporting to the doping authorities, the anti-doping authorities. So that applies to athletes and support personnel as well. So you can be sanctioned to a minimum of 2 years to lifetime. So now I'm going to move just quickly into the doping control process, because you might not be involved, but as a support personnel, you might be there and asked to be a representative for the athletes. So what would happen in this case is that the sample collection personnel, which is the DCO or the chaperone, would come up to you, come up to the athlete and notify them that they've been selected for testing. Once that happens, the DCO will ask the chaperone to produce their ID, and once they comply with that, we will continue with the sample collection process. If they are minors, it's important to note that they must have a representative at all times. So that person can be over the age of 18, or it can be any other support personnel. It could be you, the doctor, it could be their coach or their legal guardian. So once that is done and they're at the doping control station, they will be asked to wash their hands with water only. Once that is done, they will be asked to select one collection vessel from a minimum of 3, and then they will be accompanied by the chaperone to the restroom. Once they're there, the chaperone will instruct them on what to do and how to disrobe. What is important here is that we must see a clear unobstructed view of where the urine is coming from the athlete's body. So the chaperone or DCO will instruct the athlete to pull up their shirt mid-torso and their pants or whatever they have on, or shorts, mid-knee. Another important point to mention is that the DCO or chaperone must instruct the athlete on what to do, and the athlete, once they pass the urine sample, are in possession of that until it is sealed. Another important point to mention is that the chaperone will always be the same gender of the athlete. So sorry about that. Alright, so here you're seeing this is a female and a female athlete, female chaperone and a female athlete. In the case of a male athlete, you would have a male chaperone. In the case of a minor, you would have the representative, that's it, coach, the guardian, or any other representative here, just witnessing the doping control process. You'd have the athlete here, and you'd have the chaperone or DCO right there. So once that is done, they would be required to provide a minimum of 90 mils of urine. Once they collect that 90 mils of urine, what will happen is that they will go to the doping control area, and the DCO will instruct the athlete on to select one urine kit from a minimum of 3. They will ask the athlete to empty the contents of the kit. So in the kit, there is A bottle, a B bottle, and 2 plastic bags. Once they do that, they will instruct them on to check the numbers on the kit. So you have the A bottle and the B bottle, and they have to ensure that all the numbers match. So you see this number, that number, and the 2 numbers on the cap. They must all match. Once they all match, the athlete will be instructed on how to split the urine sample. So with that, the athlete will be instructed to pour into the B bottle to the amount indicated by the DCO, and then into the A bottle. So once that is done and the urine sample meets adequate specific gravity. DCO will collect other vital information like if they're taking any medication, supplements, and they will be asked to disclose other demographic information. So from there, the sample will be sent to a water accredited lab. Upon delivery, the A sample would be analyzed. If the A sample is negative, the athlete does not hear from JADCO. If the A sample is positive though, they will receive a notification from JADCO. They will also be informed of their rights to test the B sample, and that is a cost of about $350 USD to the athlete, right? So the positive sample is an AAF, which basically indicates that there is a prohibited substance that is found in their blood or urine. So if the A sample is positive, JADCO will do the following steps. We will check if there is a TUE is in place. If there is one in place, that's where the results management process would end. If there is no TUE in place, we would continue with the results management process. As I mentioned before, if the B sample confirms the A sample, so if there's also a positive sample with the B sample, we will continue. But if the B sample is negative, that's where the results management process will end. If the athlete or the support personnel does not agree with any sanction handed down by the independent anti-doping disciplinary panel, they can appeal them at the Anti-Doping Appeal Tribunal or the Court of Arbitration for Sports. So as I mentioned earlier, the prohibited list, which contains the substances or methods that are prohibited at all times for particular sports and also in competition. So you might be wondering what in competition and out of competition is classified as a support personnel. So in competition is the period commencing 11:59 on the day before competition, which the athlete is scheduled to participate in, until the end of that same competition or at the end of that doping control process for the athlete. Out of competition is any other period than that. So I mentioned earlier, if the TUE is in place for the athlete for that particular prohibited substance, then that would be the end of the results management. So a TUE, I'd like to mention, is basically a certificate for a legitimate medical condition. So some legitimate medical conditions include ADHD, type 1 diabetes, and intravenous infusion. So some instances under which the TUE can be granted include if the athlete would experience significant impairment to health, if it is withheld. Secondly, there is no additional enhancement apart from returning the athlete to normal state of health, and there is no reasonable therapeutic alternative apart from the use of this prohibited substance. So some other common health conditions include ADHD, musculoskeletal injuries, and inflammatory bowel disease. So you might be wondering also who needs a TUE. The athletes that are in any of our 3 testing pools, that could be our RTP athletes, that includes like our top level athletes in Jamaica, or lower testing pool athletes, those are budding athletes, or team testing pool athletes that include football, rugby, and netball. Other participants or athletes who need a TUE includes athletes competing at a national or international event, athletes taking part at any competition where doping control may take place. So I'm going to give you a little idea of what our application form looks like. Not sure if you can see it, but it's available on our website. It is very important to know that when you're completing the form or the athlete is completing the form, they should use capital letters when filling out the form. The doctors should also attach evidence confirming the diagnosis of that legitimate medical condition. They should also include comprehensive medical history and all results of relevant examinations, laboratory investigation, and imaging studies. They should also include short summaries of diagnosis, key elements of exams, medical tests, and treatment plans. The last thing I would like to encourage as well is to use the WADA TE checklist. It's available on WADA's website. To submit the completed form accurately and using legible handwriting, submit the form to technical@jadco.gov.jm, or you can hand it in person at our office at 1 Balata Avenue, Kingston. Thank you.
All right, Ms. Dunn. Thank you, Ms. Dunn, Ms. Yanni Dunn of JADCO for that presentation. We're going to leave the Q&A for her until later on and move on to our next presenter. Just to quickly mention two of our sponsors once again. Indus Pharma private company, I believe, who supply affordable and high quality pharmaceuticals and medications. And also MediWellness, I actually forgot the slogan, but MediWellness and Medical Practice by our own Dr. Cheryl Burke. I'll give her the slogan later on. All right, our next presenter. It gives me great pleasure to present Mrs. Pierre Patterson Walters Brown. No relation, but one of my good colleagues. All right, so for over 30 years, Pierre has been doing what she loves and loving what she does, which is physiotherapy, especially sports physiotherapy. She received her diploma in physiotherapy at what was the UWI School of PT in 1991, and then her bachelor's in PT in 2010 from the UWI. She also has a postgraduate certificate in geriatric care management from the University of Florida, and she's a well-known certified kinesiotherapy instructor since 2011. She also teaches kinesiotherapy method throughout the Caribbean, and she also has an IOC diploma in sports physiotherapies in 2021, IOC being, of course, the International Olympic Committee, and she also holds an IOC certificate in mental health in elite sport. She's the founder and CEO of Therapeutic Touch, which is a PT practice based in Maypen, and she's been a member of the Jamaica Association of Sports Medicine since 1998. And she's been a team PT for multiple teams, multiple delegations, both regional and international, spanning from Carifta to the Olympic Games and the World Championships. So today, Ms. Moore is going to speak on injury prevention in sports, which is of course a very interesting topic, so I'm looking forward to hearing this one. So without further ado, Mr. Pierre Brown.
Good afternoon, everyone. Thank you very much to the Powerlifting Association for inviting me to speak this afternoon. My objectives for this presentation is to help us understand the relevance of injury prevention in sports. I'll be trying to define injury. I'll provide a historical perspective of research in injury prevention and injury prevention models. We will examine the causes of injury, risk factors, and injury mechanisms. I hope to demonstrate how these factors influences the development of injury prevention programs and to educate the audience on injury prevention measures. So injury, it's it's a complex thing to define, given the various components involved, which might be physical or there might be a psychological aspect or both. Sports injuries are injuries that occur during sporting activities and exercise. Injury in the research literature, the IOC Consensus Paper 2020 defines injury as a tissue damage or other derangement of normal physical function due to the participation in sports resulting from rapid or repetitive transfer of kinetic energy. Injuries can be classified by the body tissue affected, the nature of onset of the injury, the context of the injury, and the severity of the injury. When we think about injury, we want to look at the magnitude of the injury. And magnitude of injury is equal to the frequency. And when we think of frequency, we are talking injury rate, which is measured as the number of injuries per hours of participation in either training and or competition. And we usually record time loss per 1,000 hours of exposure. Incidence can be defined as the number of new injuries within a given time in a given population, whereas prevalence is the percentage of athletes in a given population with an injury during a given time. Multiply frequency by severity, and we want to look at type, location, pain, disability, absence from sports or impaired function, impaired athletic performance, and we also look at the direct or indirect costs of an injury. Sports injury prevention. Now, in public health, we define injury prevention or prevention as an action taken to keep people healthy and well and prevent or avoid the risk of poor health, injury, illness, or early death. We can further classify injury prevention into primary prevention, secondary prevention, and tertiary intervention. Now, primary intervention is associated with health promotion, talks, advice on injury prevention, the use of bracing or taping prophylactically. Whereas secondary prevention, that's early diagnosing of bodily insult, so acute injury, and intervening to prevent or stem the development of disability or implementing a treatment to prevent re-injury. On the tertiary intervention, this is focused on rehabilitation to minimize or correct disability due to the existence of disease. In order to understand injury prevention, we want to look at sports injury prevention models. I'll take you from a conceptual model to what is currently being used. So we look at the conceptual model, a biomechanical model, injury causation model, TRIP, and Haddon's matrix as it is applied in sports injury prevention. Prior to the 1980s, most of the researches were epidemiologically related, and this provided significant amount of information regarding sports injuries, but they found that there was limited research on injury prevention itself then. There were a lot of concerns about athletes' health and how injuries affected performance or the lack thereof. Additionally, they found that there was a rising cost burden that rehabilitation of injuries placed on individuals, teams, clubs, healthcare, and insurance systems as well. By the 1990s, out of this concern, there was a 200 to 300% rise in studies on injury prevention. When one concern considers how to reduce sports injuries and the burden of injuries on sports, we must first understand how injury prevention models came about and how they function. Willem van Mechelen in 1987 and later on with others in 1992 developed an injury prevention model also known as the sequence of prevention. This provided a framework that drove increase in injury prevention researches and the development of injury prevention programs. It's a four-step model. First, he said, step one, we are to look at the magnitude of the injury. Step two, establish the causes of the injury. In step three, you think about the idea. It's an idea for prevention. And in step four, you're going to assess or test the prevention model that you came up with. Lewis in 1994 and Hagel and Lewis in 2004 developed other biomechanical models, but they were considered more research-based and lacked clinical methods and application that would directly impact the athlete or preventing injury. Barr and Crosshag came up with a causation injury prevention approach. And this posited that a better understanding of the causes, risk factors, and the mechanism of injury would augment the development of injury prevention measures and programs that would lessen the number of sports injuries. I'm not sure how well you can see the slide, but we're going to look at the risk factors for injury, the mechanism of injury. When we look at this, we're thinking in terms of modifiable earthquake or non-modifiable factors in injury, of injury. Some non-modifiable causes are what we call intrinsic factors. So we're looking at age, sex, body composition, health. We're looking at the physical fitness. We're looking at the type of tissue, muscle strength, power, O2 uptake, range of motion. We're looking at the person's anatomy. We want to look at their skill level and of course the psychological factors involved. And those are the intrinsic risk factors. This makes the athlete predisposed. So there's a predisposition for injury here. Then we want to add our extrinsic factors or modifiable risk factors. And these include exposure, sport factors such as coaching, rules, referee. We're looking at sports equipment. We're looking at the environment. So what is their playing surface like, etc. And added to the intrinsic factors, this now makes the athlete susceptible to injury. If we come across, we're going to find now, in our questioning, we are going to want to ask or look at what are the inciting events? How did the injury come about? And this includes questions on playing situation. We're looking at the player, the player's attitude or
behavior. We're looking at the opponent's behavior or attitude to play. We're looking at a gross biomechanical description or whole body description to see how this adds in. And then at the top, you will see where we have the mechanism of injury. And so the mechanism of injury involves the inciting events added to your external or modifiable risk factors and your intrinsic or non-modifiable risk factors. And this can lead to injury. We're moving along to the TRIP or Translating Research in Injury Prevention Practice Model. The TRIP framework proposed by Finch in 2006, next slide, expanded on the model of Van Mechelen and added 2 additional stages. It emphasized the importance of translating research findings into real-world practice and acknowledging that any successful sports injury intervention must be adopted and sustained both by the coaches and by athletes alike. This is the model. So, it does include Van Mechelen's 4 stages and 6 additional. So 1, you'll be collecting data on the types and rates of injury. 2, identify the risk factors and causes of the injury. 3, you're creating interventions to address these identified risks. And then you're going to be testing the effectiveness of the intervention in a controlled environment. They added understanding how real-life environments and contextual factors, such as behaviors like I mentioned before of the player, the athlete, and the opponent, how this can affect and how you need to adopt your preventative strategies. And lastly, assessing whether the strategies are successful in actual or real-life situation. Another model by Barr et al. In 2005, next, recognized that a purely biomechanical approach to analyzing risk factors and inciting events did not provide a holistic picture to adequately determine or decide on preventative measures and interventions. They acknowledged that there was a lack of studies on the issue or this intervention. So in 2018, Bowling, Van Mechelen et al., these are members of the IOC Olympic Medical Committee, they revised the sequence of prevention and recommended that a more context-sensitive approach to understanding sports injuries and more qualitative research is needed to foster new perspectives in injury prevention. Our next slide shows the socio-ecological view of sports injuries. So there are differences in injury prevention approaches between different sports, different countries, that might contribute overall to different injury prevention outcomes. One of the barriers identified was the effectiveness of a preventative program, the lack of consideration about the interrelationship between physical, biological, economic, and social aspect. So this model basically gives an overview of what a injury prevention program should look like and embodying the socio-ecological aspect of the athlete as it relates to injury. Okay, in terms of injury prevention measures, next slide, having reviewed the literature, the next step is developing management strategies for injury control. They adopted Haddon's matrix. In 1997, had designed an analysis tool for motor vehicle accidents, and his model was adapted to analyze potential injury prevention methods in sports. So in terms of sports injury prevention, we want to look at risk management, which includes identifying, assessing, and controlling risk, surveillance, of course, risk assessment, risk evaluation, which is determining how significant these risks are and how important are the findings to athletes, their coaches, clubs, and even associations. And then they'd move further into risk control. So we want to implement measures to control the levels of exposure, plus or minus the consequences that would be presented were the hours. The IOC injury prevention policies. The IOC has different consensus papers that are on their website. And so in terms of injury prevention, they did put out a paper, and it looks at injury surveillance in sports, data collection, reporting, load management, youth and adolescents, and injury prevention programs. In terms of large-scale injury prevention programs, I'd like to mention the FIFA 11 Plus, which we might be familiar with. There's a Canadian province of Quebec model, and it speaks to ice hockey in Canada. The NCAA has a wrestling consensus paper that looks into weight management in wrestling in terms of preventing injury. And one that I found very interesting is a New Zealand Sports Smart model of 1999 that looked at rugby, soccer, and actually accident compensation in New Zealand. Next slide. So their Sports Smart model included consensus statements or guidelines on screening, warm-up, cool-down, physical conditioning, technique, fair play, protective equipment, hydration and nutrition, environment, injury reporting, and injury management. What can we do to implement small-scale injury prevention programs? Teams, clubs, their medical support teams should brainstorm. We need a pre- and post-season surveillance, which we can do as locally as team and then club level. We need to have a database collected on injuries, even if it's epidemiology, meaning the numbers of injuries that you have, and maybe looking at gender, but epidemiologically based. Education, we need persons to talk or give talks on injury prevention. We need to look at behavior changes within the clubs, teams, or athletes in general. We need to put in place risk management processes, coordinating and implementing of these changes that we think about. On the measures, we would then want to post. Next slide for me is periodic health examinations. Did I jump? Periodic one, two back. Right. Periodic health examinations. So as I stated before, the IOC has consensus statements in this regard. It's a scientific and clinical evidence-based article that states that PHEs are important to screen athletes for present and future health problems, to identify risk factors for injuries, to identify medical conditions, and what can and should be done immediately. I'm proud to say that the Jamaica Sports Medicine Association has conducted PHEs since 2022. It's an ongoing process, and we conduct 3 throughout the Cornwall, Middlesex, and Surrey, and we screen high school athletes. So listen out when we advertise and invite schools to come. Next slide. Warm up, cool down, stretching. These are preventative measures. We'll have a speaker that goes into this, but warm up and cool down is very important. Stretching, the research is still out there as to whether it does prevent injuries, but stretching, dynamic, active stretching, the debate lives on, but it plays some role in preventing injuries. Protective gears, very important, and there are some examples in my photo. Each sport will have their different protective gears that are in their rule books, and these gears have to be worn, and there are a lot of research out there on protective equipment. Training progression and load management. This as it relates to the team coaches, to the medical support team, when to increase, when to decrease, when to taper. Training factors to look at: magnitude of the load, the rate of load application, technique, training surfaces, equipment. Load factors, we're looking at frequency, volume, speed work. Footwear, shoes, when do you change the shoes? You can't be going to competition and wear a new pair of shoes. We want to look at capacity factors, age, psychosocial factors, load tolerance as it relates to how can this athlete manage the load that you're putting on them? What's their nutritional status, medication use, etc. And of course, we have to look at the athlete's ability to adapt or tolerate load. Having reviewed all of this, defining injury, classification of injury prevention, the 4-step sequence in injury prevention, can we ask ourselves, where are we in terms of injury prevention? In your clubs, for your teams, for your associations, in Jamaica? What is the magnitude of our injury problem? Are we serious about injury prevention in sports and protecting our athletes? Can we collaborate in tackling this problem as an athlete, a coach, medical staff, club, association, in academia, the researches? What of our local Olympic committee? What are we doing as a nation? Ladies and gentlemen, I leave you to draw your own conclusions on this topical issue of injury prevention. I want to thank you for listening, and I hope I have opened your minds to ideas as to what we can do in terms of injury prevention. Thank you.
All right. Yes, Mr. Brown, thank you very much for that presentation. I don't know if you saw me while you were speaking, I was nodding over and over as you were speaking and making your points. Just to make a quick mention, again, of 2 of our sponsors, Suppligen, a major and loyal sponsor of the NPAJ. And speaking of the holistic approach to athletes, we have a couple of dental practitioners here over to the side there, so I just want to make a mention of them. So during our intermission, if you will, you guys are free to go ahead and speak to the dentists about different aspects of dental health, especially regarding athletes and I guess in general. All right, so on to our last speaker for the session, and a very fitting follow-up to Mrs. Brown's presentation. She mentioned the periodic health evaluations, mentioned the JSM, of course, and so our next presenter is none other than Dr. Kevin Gwynn L. Jones. Doc, what's the L for? Leroy? Who? Louise? So S is not silent, it's not Louis? All right, I'll let you say it. All right, Doc. So yes, Dr. Kevin Wynne Louis Jones is a consultant orthopedic surgeon at the Mandeville Regional Hospital and an associate lecturer at the University of the West Indies, I believe, in orthopedic residency program. Right. He was a Bachelor of Medicine, Bachelor of Surgery, MBBS, and has a Doctor of Medicine in Orthopedics, and is also, that's from the University of the West Indies, and is also a Fellow of the Royal College of Surgeons in Edinburgh, FRCS. He's a former president of both the Jamaican Orthopedic Association and the Jamaica Association of Sports Medicine, and he served as team doctor for several national teams, ranging from Carifta as well, regional championships, and international championships, including the Olympics and the World Championships. It's not mentioned here, but he is also a former competitive athlete in volleyball and a thrower himself, and a bit of a throws coach too, right? Are you ready? All right. So Dr. Jones is going to speak on establishing a national sports medicine service, the JASM model, which I think is a fitting follow-up to Mr. Brown's presentation, as I mentioned. So without further ado, Dr. Jones. Thank you.
Good afternoon, everybody. I'd like to thank the National Powerlifting Association for inviting me to talk. I would like to be off to the side so I can see the screen because there's no screen here. I don't have a projector here. So, yeah, move this across. So, I'm here to talk about establishing a national sports medicine service. And I presented this topic before a couple of years ago, and things have changed a bit since then, but the essence of it remains the same. All right, so I have a couple of disclosures. And the reason why I put all these disclosures up there, because I think after looking at them and hearing about them, you'll get a feel of my issues, and you'll be able to detect my bias and my biases and so forth, and understand the talk. So, as Diala said, I used to compete in high school, in a couple of national teams, Carifta, CAC, etc. And I had injuries during that time, and it was challenging. I kind of grew up deep rural. I was at Knox and Monroe, so getting specialist attention took a bit of travel and times before toll roads and bypass roads and so forth. So to get to Kingston, they're talking in excess of 2 hours and so forth, I think. So I went through the athlete's frustration of dealing with injury and trying to get specialized care for it. And I also went on from there, I went on to college. I competed in college for 4 years and, well, was exposed to a top-class healthcare system. I had surgery the first year. I went within 3 months of going, I had surgery on my knee, and then had to come back from that. And then since then I've gone on to become an orthopedic person and have to deal with a lot of sporting injuries. And that's me at one of the championships. And the reason why I have the Jamaica Association of Sports Medicine thing on center there is that a lot of the talk is based on that. I was a past president, so some of it might be biased towards the association and so forth, so don't get too bad about it. All right, so that's Jamaica Association of Sports Medicine. It's a brief background, founded in 1969, and they tried to provide sports care, specialized sports medicine care to athletes, and these athletes at all levels. At that time in 79, you must recognize that there weren't a lot of professional athletes, so these were mainly amateur athletes, because remember the 3 A's in, one of the A's in J3A's and one of the A's in the IAAF was about amateur athletes. That has since changed, so the dynamic has since switched a lot. But that's where it started. And the association tried to provide health care, expertise, sports medicine care to athletes, whether they were seen in a clinic that needs to hold at the arena or at the various hospitals, in particular the University Hospital of the West Indies, where one of the inaugural presidents, Dr. or Professor John Golden himself, and his residents, Paul Wright was one of his residents there, they would try and see and facilitate athletes care through the clinic. After that, persons like Mr. Christopher Rose and Dr. Akshay Mansingh, they tried to facilitate assisting athletes through the orthopedic clinic at the University Hospital of West Indies. And I have to work with both Mr. Rose and Dr. Mansingh, and we've operated on several netballers and national footballers and other cricketers and other athletes through the orthopedic clinic at the University Hospital of the West Indies. All right, so like I said, I'm from deep rural, and the issue with everything being in Kingston is that Kingston pretty much it far, so it's kind of hard to get to town when you come from rural. And they've since paved that road. That's the road that my mother's house, but the road has since been paved. But coming from afar and trying to get to Kingston to see somebody could take up your whole day. You know, I remember coming a couple of times to see Dr. Wright at the UWI clinic, and my father used to work at university, and just being there the whole day, it was taxing. It was very taxing. And you know what the great Jacques said, the world at level, and so for us rural types, it wasn't the same thing. People live in Kingston get a different perspective on what we go through as deep rural athletes. And yes, I've carried some belly issues for a long time, so try to level that off. All right, so my whole idea of having come through all of that frustration as a student athlete, as a coach, I guess I coached, I volunteer coach high school for like 26 years. One of my kids still has 2 records at champs for over 20 years, you know. So having gone through all of that and dealing with it from the rural side, before I went off to college in the States, I had visa issues and so forth, and I was asked to write a letter to the embassy to justify me getting a US visa. Still have some issues over that, but I had to write this letter. But in the letter, which I found already, one thing I wrote about was establishing a sports medicine type setup in rural Jamaica, pretty much to service rural athletes. And so that idea has been kind of translated to trying to provide it on a more national basis. So Arthur Ashe, the Arthur Ashe principle, or this principle was assigned to Arthur Ashe. If you don't remember who Arthur Ashe was, he is still the only African American or black tennis player to win Wimbledon. That was in 1976. He was the first African American. The first African American was Althea Gibson back in 1957, and she won both Wimbledon and the US Open, which is 57 and 58. Sports trivia if you ever get in one of those things there. So but Arthur Ashe came from very humble backgrounds, and this is before lots of stuff and things. They were playing with wooden rackets and so forth still then. And what he said, and this was based on his own life experience, was that to achieve greatness, you know, this is what he tried to achieve. They outlined 3 basic things. One is to start where you are. Wherever you are, whatever you have, use it, you know. And then start where you are, use what you have, whatever it is that is presented to you, and then do what you can with it. And that is a very almost simplistic but very critical principle. And when I hear a lot of chat nowadays, I mean, when you talk about establishing a sports medicine center, people talk about building huge structures, then you have to find people to staff it, etc., etc., etc. And it, like the Trelawney multi-purpose stadium, inevitably if you do things like that, they become white elephants. So to make it as appeasing as possible to the powers that be, we try to present a situation where we can provide a service without necessarily any expense to the powers that be and their associates. So the objectives were to determine the feasibility of seeing if we could implement the sports medicine model, the Jamaica Association of Sports Medicine model in other parts of the country. So when I finished orthopedics in 2003, I was kind of prostituting my services in the Southeast Regional Health Authority for a while before I got drafted to Mandeville, where I've been since 2005. So in fulfilling my letter to the U.S. Embassy, I don't know if they're still keeping tracks on me, but yeah, I was to return to country and try and set up this sports medicine unit. So what does this involve? So at the Mandeville Regional Hospital and several hospitals, there's a hospital. So this is what do we have? We have multiple public hospitals all over the country. And these public hospitals are physical structures which you'll need to do whatever. They have an outpatient department in multiple ones of these in Mandeville. Like I said, we have an outpatient department. Orthopedic clinic is there on Mondays and Fridays. And through that, the orthopedic clinic, we try to facilitate seeing these athletes. Now, the system was kind of informal at the time. I spent most of the time, I volunteered coach field events for like 20-something years. So my talk would have a strong track and field bias based on all of that. But I've seen and managed athletes from other areas as they caught on to what it is that was going on. So like referrals would come from either people calling me directly because having been in the trenches, coaching and stuff like that. Coaches have your number, some athletes have your number, then agents get your number and other things, and it kind of expands from there. And in some situations, like I said, sporting associations, like the GSM, we're at most of the major meets, so when people get hurt at these meets or whatever, they need some specialized care, through some member of the GSM will get a call. We're at a meet in South Clarendon, and I said, boy, go in XYZ, can they come and check you, such and such. It's kind of a very informal setting. But as the GPs and so forth caught on, and we had more GP type persons registered with the Sportsmen Association, that kind of referral pool kind of expanded. All right, so some of the problems we experienced. So when it just started, I saw pretty much everybody, and then I tried to document everything. That's what this study was based on. I wrote down everything in a large hardcover book about who was seen, school, sport, event, etc., and the treatment and so forth. Since then, I've gotten a records clerk who has been able to decipher my handwriting, which is not so great sometimes, to be able to document these things for me. So over the last 2 years or so, she has been doing that, which has been a great assist. I don't have to spend too much time trying to write and document. Some of the issues sometimes you get a rush of athletes. Sometimes schools come with like 3-4 guys or 5 persons, and then you're trying to see everybody and get them through imaging and so forth and things, and then do whatever that you need to do, and sometimes and end up documenting like the day after or later on in the clinic. And with that, once in a while you miss sometimes some small things which will come back and bite you at some point. And like I talk about the legibility of the notes, a lot of that is on me. So the Southern Regional Health Authority is a diagram, a map of Jamaica, and it's kind of region of colors showing the different regions. So my region, the Southern Regional Health Authority, entails Manchester, Clarendon, and St. Elizabeth. However, if you recognize how healthcare works and all of things work based on transport and accessibility. So for us, we're up in the hills. We're like 3,000 feet above sea level, plus or minus, depending on what, extended from the Moko Mountains all the way across to the mountains in St. Elizabeth, the Santa Cruz Mountains in St. Elizabeth. And also in the mountains, we share mountainous borders with places like South Trelawney, South St. Anne, and then on the coast side, Westmoreland side, and South St. James as well, because Catadupa up in St. James side is on the northern border, shares the northern border with St. Elizabeth. So it's easier for persons like those to get into like Black River Hospital. Easier for persons like St. K Valley in St. Anne, as far as Alexandria and so forth, to reach the Spalding Hospital, Percy Hospital, and then from there they get funneled to us. And then I think about all the schools in the area extending from that side go as we to in Clarendon, Manchester, St. Elizabeth, and then some of the surrounding areas. So that's kind of like the catchment area of what we got. That has since expanded for various reasons. So as a result, so with what we did is like, so we, after documenting all this stuff and thing, we went through and tried to analyze it and see the athletes that we saw, how many athletes, how many visits to the hospital, different sports, and then what was done. So we had about 245 visits. I documented that visits because sometimes you had one athlete returning for a different injury at a certain period of time. And there's a male preponderance there. No surprise if you watch more sports, and especially like track and field, you know that as they approach class 1, the female population of athletes tends to diminish. So you don't have a lot of class 1 female athletes. So no surprise there. So 55% were 55.3% were males, and the other 44% were females. And this is the distribution of schools that I saw. This was between, I think it was 2017 and 2019. Manchester High School, which is nearby, the students can walk to us if they need to, although I drive everything there. So other kids from Stets, and then after throwing the thing as well. So the principal of Stets is our old Monroe guy, but he was a kid to me still. He's our president of ISA. But so with that kind of bond, any issues they have with the Stets athletes, although as a Monroe man, we have a very tense rivalry with Stets and things, and we don't like to see them personally. But yeah, as a medical professional, I have to put that aside and see them. So saw quite a few people from Stets. Ironically, I didn't see a lot of people from Monroe during the time. Saw quite a few kids from Edwin Allen. Miss Brown works with the Edwin Allen team. And so a lot of kids came up to us from there. Tasius Golden, which is in Clarendon. Rossi's from a coach that knew me from when we were in the trenches, so that happened there. Petersfield, which is in Westmoreland. Like I said, the throws coach there, who has now moved on to Greener Pastures, is now with the racers and things. So, so me and him were pretty kind of tight, so him tend to get the time he'd bring the athletes up to see me. Homewood, Knox rival, so I have to show my bias. I don't really like Homewood people, but couldn't really disrespect. I mean, they wanted help. I offered my help to the Homewood people. Mount St. Joseph, which is a private prep school in, and now have a high school component in Mandeville. Hillel, so card there, so I know the mother of that child very well. So she decided to bring her down to see me for 2 sets of injuries. One had to operate on, and the other one just needed some casting. And now she's on scholarship. She's a footballer. You know, she's overseas playing football at some high school. Belfield, which is up in the hills of Manchester. Spalding, my hometown. Only one athlete from Spalding High. St. Jago, which I come from St. Catherine. Spend a lot of time in the trenches with Jago coaches and so forth and things. So you don't have an issue, and they kind of call me. Queens, the head coach of Queens was a guy who used to coach at Manchester High School. So when he went to town, he would still want to send the people down to see me. And then Magate, which is a school in St. Elizabeth. So that's kind of like the spread. That's the spread when you look at it on a pie graph in terms of the parishes that they come from. 7 parishes: Manchester, St. Elizabeth, Clarendon, St. Catherine, Hanover, Westmoreland. I would lump Kingston and St. Andrew into one. And that's kind of the spread there. Sport distribution, no surprise there. I told you about my strong involvement with track and field. So most of the track and field people know me in some way or form. A lot of people at the J3s, my father used to be with the J3s. So over the people in the J3s know me and things. So if something happens, they call me directly and things. So that's the track and field bias there. A lot of football injuries. Some people in track and field play football, so a lot of football persons. One cricketer, one badminton. If you know any history of badminton in the country, you have to recognize that Manchester was like the center with Coach Ranger was like the center of badminton for a while. The number 1 players came from that side for a while through Coach Ranger and so forth. I think so. We have quite a few bad players in the area. At that time when I did this study, there was only 1 person. I've seen many since then. Basketball, quite a few schools. Knox, Manchester do pretty well in basketball. So when you looked at it in terms of track and field, that's where most athletes came from. Divide up into the sprints, 100 to 400. Middle distance runners, 800 to 15. Long distance runners, greater than 15. Then the throws and the jumps, horizontal and vertical jumps. The sprint hurdles and then the intermediate hurdles. As you can see from the graph there, the majority of the persons that we saw that had injuries or issues, sometimes there were issues that needed to be sorted out, muscle imbalance, foot problems, flat feet, etc., and so forth and things. So the majority of the athletes we saw were track and field we saw were sprinters, you know, and I guess with a high demand, high energy, high impact sport, you can see why. Middle distance runners less so, long distance runners less so. Throws the least, jumps with all that ballistic stuff was up there. Sprint hurdlers more than intermediate hurdlers. That's kind of the distribution that we got. And a lot of that goes to, in terms of like when Pierre was talking about injury prevention when we do our periodic health evaluations and so forth. We always ask what sport they do and what event they do so we can guide them according to how as to best prevent injuries in those areas. So the National Distribution of Orthopedic Clinics, so this is what we have. No, this has expanded since the time. The asterisks that are there are those that have come in the last year. But in Kingston, at UWI and KPH, the Southeast Regional Health Authority have 3 clinics up at UWI, 3 at KPH, and in Spain you have 2. In my region, Southern Regional Health Authority, we have 2 clinics at Manivellers, Maypen now, Dr. Franklin out in Maypen, and Dr. Rodney now in Black River since, I think, early this year. In the Western region, this is Cornwall side, you have 3 clinics at Cornwall. They also have orthopedic surgeons at SAV. You know, like 3 or 4 guys out there. And in the Northeast region, they have orthopedic surgeon Dr. Matt Doyle is at St. Anne's Bay. And no, I know Dr. Miller has gone to Nutter Bay. So there are orthopedic clinics. So these are things that you don't have to build, already in place all over the island. So this is what we need to use to think there. Now, everything always kind of comes down to cost, and I did 2 lines up of costing here. Now, the costing was for doctors and for physical therapists. And I had this conversation this morning with some friends and so forth. You can be the most amazing doctor in the world, but if you don't have adequate physical therapy, all you have done would have come to naught. You know, and I've seen it, I've operated on, you don't need to clap all of you, I don't check this. You can do the greatest surgery in the world, and if the person doesn't do adequate physio, they end up with a stiff hand after repair all the tendons because they have done nothing, you know. So it's so in looking at this, it's not just about being diagnosed and like initially treated by a doctor, but it's critical that the physical therapy departments be upgraded to be able to, if we want to do this thing right, be made more adequate. Because a lot of them we have good physical structures, large enough spaces and so forth, and things. The equipment might be lacking, and then the staffing more critical is lacking. So in terms of getting like early appointments to get early treatment is very challenging. We see it a lot in our trauma patients, especially in our flexor tendon injuries, who you want them to be seen right away. You pretty much have to call and beg somebody to try and work them in early. You know, so in pushing this national agenda, you really has to look to upgrading physical therapy departments and personnel in order to facilitate the appropriate rehabilitation that is needed to optimize the outcome from injury and beyond. So I did 2 sets of costing, and this was based on the gazetted salaries. You recognize that we've had increases in salary since then. So the figures are kind of irrelevant, but the principle is what matters. So if you're going to employ an extra person to deal with everything and so forth, I think, and you're going to employ an extra physical therapist or 2 to work in the department or whatever, the cost at that time were well, hold on, this is the next slide. Yeah, so if you were to employ people full time, it would cost about 15 million, something like that, about in 2019. That's the same thing, they've gone up. Now, if you want to do sessional work, so instead of employing somebody full time, and trust me, the wards, the hospital itself does need a lot more physiotherapists to just deal with the hospital population. But if you want to penny pinch and decide that you just deal with an extra personnel to deal with athletes, you just need to bring a doctor part-time, and those were the sessional rates there, and then a physical therapy, 2 additional physical therapists part-time, so like 4-hour sessions, which could be done after hours. Say the hospital people between 8 and 4, whatever, and then you do like the athletes between 4 and 8, paying a sessional rate. You know, quite feasible, and the cost for that, doing something like that, would be quite significantly less. What was that? A third, almost a quarter of what the cost was if you were going to employ somebody full time. And these are things that you can be looked at, and that be significantly less than trying to build some structure somewhere that only a few people can reach, and you won't be able to staff it. All right, so when you look at the whole picture, it's feasible as it is now. It's free to the government, so the government hasn't been paying anything from us to be doing this in Mandeville for the past 20 years, you know, and multiple athletes have benefited at all levels, from the high school level to professional level. Several athletes we have have worked with us and passed through our hands have gone on to win medals and so forth at the World Championships and the Olympics and so forth and things. We'll call it in, but yeah. So it's quite feasible if you really want to get this done and not just sit and talk about it after we have a great performance or after an athlete gets hurt and you hear they don't get the surgery, they don't get this or that or the other, and then they get kind of lost in the wind and frustrated, and it reaches the press, and then somebody jumps in and says, well, rare this and rare that, and the person gets attention from that. And that shouldn't have to be the case for somebody to receive basic sports medicine care within our system. So these are just a couple examples of athletes that have passed through our hands. This is a picture of somebody who has a tibial spine avulsion. Right. So that's the tibial spine there. They look from the side. It's there. And why is that critical? And the critical thing with the tibial spine is that it serves for part of the attachment of the ACL footprint, especially in the skeleton, for the ACL footprint. And the skeletal immature, this is what tends to happen. They tend not to rupture their ACL, but they tend to pull it. The ACL tends to pull out from the bone, and it comes off with a piece of bone like that. So it's critical. It's important that you try and get the fixes in as early as possible. Now, the good thing with these is that because they're skeletal immature, it has a timeline on it. You don't want them to start to heal and go inside. And so the staff at Manable have kind of bought in, the nurse anesthetists and so forth. So generally, something like this happens and they come to us, we can put on an emergency list and get them done. Because the average Jamaican, I think, is a sports fan in all way or form. And so usually you put it to them and they will facilitate him getting done on the emergency list at some point in time. Not at the expense of some life-threatening thing, but in a reasonable period of time. So if you do a computerized tomography scan there, you can see there on the coronal view, you can see the spine there, recognize the ACL is attached to that, and the physios will tell the ACL is critical for knee stability. That's it there. This is the approach to it. This is one way we fix them. This is we put a screw. The screw here goes across the growth plate, which doesn't really cause a problem. We used to be apprehensive about violating the growth plate in the skeletal immature because you worry about growth arrest and so forth, but it doesn't really happen when you use a 4mm screw. And the guys from Buster kind of reassure that not to lose any sleep over that. So we tend to go across the physis. If you're very, very nervous, you can use a double pitch screw and not cross the physis. So the physis, that's the growth plate of the proximal tibia, there, that dark space there, which is cartilage. So you use that screw which has differential threads on it, so you use that to compress it and then all the way. And sometimes what we do is actually we pass wires in their pivots across there into the bone fragment to hold it down, to spare the physis. But like I said, it has been found not to be necessary. This is a kid. This is a kid from one of the rural schools that came to us, who ended up having a defect in the pars interarticularis. That's the part of the bone between the two articular surfaces of the facet joint. So this is a superior facet, this is an inferior facet of the same vertebra. When you come down here, so you notice that they kind of run in a straight line, up and down, up and down, up and down, up and down. If there's a defect between the part between the articular surface and the pars interarticularis, the condition is called a spondylolysis. Thank you, sir. And if you have a defect there, you can get one vertebra standing forward and the other. And so we've seen these. Usually we see these, we send them out for the spine guys to decide if they need surgery or not. Most of them don't, provided they're not sleep, provided they're stable, and we just rehab them with what? Physical therapy. And this kid went on to do well. And lastly, this video here, this is a kid who took part in champs this year. Was pretty good, was one of the people from 1 to 400 meter race. That's a CT scan of his ankle and foot. And then what so between his semi-final and final, he had significant foot pain which prevented him from continuing. When I examined him, he had significant tendons over his talus. did an X-ray which suggested that he had a stress fracture in his talus. The computerized tomography scan there confirmed it. As you can see it here, and the next one, let's look for it. So that's the talus, and it's navicular. Oh, and that's it here, navicular. So look for it coming up there, right. So he had a stress fracture of his navicular bone. So this was just this year champ. So he had to be pulled. He was one of the favorites for the event. So he had to be pulled. He was from out of region. But again, know the coach from a long time, blah, 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 blah. Brought him to the hospital. So the champs was the week, and we operated on him the Thursday after that. So we did his operation the Thursday after that. Ran 2 screws across it, and we had to put bone graft in there because it was a significant stress fracture of his navicular. Ran the bone graft in there. This was, like I said, the Thursday after champs, and then and he's healed. This is him now. You've not seen the fracture line there. So he used to come back next week to take out the screws. So in summary, so it's quite feasible based on what we have done in man, what we have experienced, what we continue to do, to establish sports medicine type clinics based on the Association of Sports Medicine, Jamaica Association of Sports Medicine model, where government employees in the system see the athletes there. And this is of no extra pay to us. This is of no cost to the patient. The only thing they have to pay for is for implants if they need it, like you have to buy those screws. Or the government was doing imaging for a while, but they stopped. This is apart from X-rays. So the X-rays would be at no cost to the athlete, but they need the MRIs and CT scans they need to pay for it. All right. And like I cannot overemphasize the point. In order for it to be successful, we have to be ensure that we have adequate physical therapists that we can rehab these athletes after their operations or their period of treatment. Many thanks to Dr. Steve Mullins, another big track fan, knows his stuff very well, for facilitating me on this ride over the past 20 years. The orthopedic outpatient department staff, everybody associated with some school. So usually when the athletes come, you have somebody from whichever school there, some States person, Manchester High School person, and they quickly ensure that the docket gets pulled and then the athletes get brought to me and sorted out. So you have a lot of people in the clinic who are vested interest in the athletes because they were at their school. The head of HR still is Ms. Powell. She gave me a lot of the information that I used to get the figures. Mr. Thompson and Mr. Peart, Mr. Thompson was a maintenance guy who's official at Champs. So he tends to, when the kids come, walk them through the whole registration process and get all the paperwork and sort them out. Mr. Peart, a Stetsman, so I don't like him. When the athletes come, whether they come from Stets, Board or wherever, he will help to sort them out, get the dockets and support and thing. And then Mr. Williams, who was in the ortho department at the time, is now the head in the physical therapy department. He's now the head of physical therapy at Manama Regional. But still, most of the physical therapy is done outside with the therapists in the area who try to help these athletes to get through. That's it. Thank you very much.
All right, Dr. Jones, thank you very much. We're now going to our Q&A segment. We've got 3 presenters from the first session. We already took questions from Dr. Bateman. I don't know if he's still online for further questions. It's done, you can come. So we have Dr. Kevin Jones, this is Pierre and Patterson Brown, and is Yannick Dunn available for your questions.
Before we get into Q&A, tech support, I am going to ask you to put up my references. They were beyond the conclusion slide, if you can. Thank you. Some persons, I thought it was being queued. Thank you. So those are my references, and I'm sure it will be shared. So we are now open for questions. Any questions from the audience?
First question. Who's first? You didn't mind? Oh, okay. Huh? I'm not sure. I'll check.
Thank you. Good afternoon, everybody. I'm Pat Lucid, physiotherapist. A question to Ms. Dunn with respect to when and why. You mentioned urine collection, but what about blood testing? Can you give us a little insight into that, please? Thank you.
Yes, we conduct two different type of blood testing on athletes. We test for GH and also the ABP profiling of the athlete's blood. So we do that over a series of tests. It is normally conducted probably, we don't really have a time period per se, but they're done at least 3 times in 1 year to profile the athlete. And it's just like the urine sample where you have an A and a B bottle. They are the ones that actually, after the BCO comes in and withdraws the blood, they are the one that actually puts it in the vactina and seal it. So we have no control of anything.
Any more questions? All right, one more.
Afternoon again, everyone. Thanks again to the presenters for all their presentations. Well done. Dr. Jones, quick one for you. So based on this model that you've looked at, which indeed probably you and I both know works in so many other parts of the world, but we won't bother go there. What has there been, what have the conversations been like with the government in reference to, you know, some form of official implementation of something like this? I mean, you know, because even in terms of the numbers that you showed, they really aren't drastic. So has there been any kind of conversation, be it with, you know, the Ministry of Sport or the Health Services Ministry in the government, you know, and what kind of feedback have you gotten on that? Thank you.
All right, so you recognize that the model was like always done from within. It was always the Sports Medicine Association of people who kind of did this. So when I did this when we presented in 2019, there was a lot of chatter, just like after 2008 Olympics when you heard about all these great things that were going to be done and nothing has been done. So there was a lot of chatter about following through. I got contacted by different persons that were calling in names, but with different associations. So I had a poster presentation which kind of summarized the whole thing. And they asked for this and that and that. They asked for it. I sent it to them. They said they were in contact with the Minister of Sports at the time. They wanted to see it. And the talk went on and on and on. But it's been 8 years since the poster resurfaced the track in Montego Bay and so forth. So I'm not, I'm doing what I can from my point of view. The information is out there, and every time something happens, there's a lot of talk about what needs to happen, but I don't know if anybody actually goes in to do the groundwork to see what needs to be done. So I've only had platitudinous statements coming from different places. I've emailed the thing to whoever and so forth, but nothing. I've been contacted formally and sat down to figure it out, because it's pretty simple to work out when you think about it. It's not rocket science. You just have to get the personnel on board. And if you look at the distribution of persons across the country, most persons, you Matt Dolan saying that, you know his mindset, you know. Most persons have an interest in the athletes doing well and so forth and things. And it's not difficult to kind of channel that information to providing the service without any cost. If you're just doing it at that level, you want to up the top, you can do whatever. But just the basic stuff, which is critical at sometimes. So A lot, so some night, not a whole per night, but some quote unquote interest and some chatter, but nothing official, no sit down to say let us iron this out and start this.
Well, Dr. Jones, let me ask you as well. So there's talk now about having physiotherapists in primary care facilities, and I think St. Anne's Bay has started that. So the physiotherapists in the health center. What do you think of that concept, and would it maybe contribute to this?
Great. The more physiotherapists they have and the easy access to physiotherapy, great. Put them everywhere. I mean, right now I know from a fact that this is both dealing from a trauma side and a sports medicine side that we just don't have enough in the system. We don't, and the trauma patients suffer, and then also the athletes. Well, fortunately for most athletes, the schools eventually take, but some of the athletes suffer who can't afford necessarily to get private physical therapy. So if they can get them in the health centers, great. But I think the hospitals are still very underserved, you know, and each hospital should have a full complement to serve the ward person and outpatients in a timely fashion, you know, because you know the earlier you can get them on the physio, the much better they will do. So if they can do that, that will be great. Hope it's just another one of the conversations that it tends to happen, and then 10 years from now, when I need personal physical therapy, there's none in the health center.
All right, as usual. Any more questions from the floor? I mean, I can pose one more. All right. All right, Mr. Brown, so you mentioned, and we've had this conversation before, the need for sports medicine research, epidemiological research locally. Give us your thoughts on that.
The question was if we need to be doing more sports med research. I think that it is very important and very critical that we do, start a collaborated effort. There's the Jamaica Sports Medicine Association. We are covering sporting events. We travel with members of the association, travel with teams. There is the faculty at UWI, and I find that we are not putting out enough research on sports injuries, sports injury prevention. Most of the models and most of the textbook, as you might know, are written by persons in Europe and Asia, US, Canada. But we have to put everything in context. What of our West Indies and our Caribbean athletes? Are they different, quote unquote, than European athletes? Maybe, we don't know, but where's the research? We don't even have data. Well, we have raw data, but nobody has taken the time to really analyze and put out a research paper. And we need to get scientific about sports-related injuries, sports management, etc. We need to be sharing, we need to be looking and putting out the research. When you go to an IOC conference or a World Athletic Conference, rarely you see anybody from the Caribbean presenting. I've never been to one and heard anybody from the Caribbean presenting. And we have the human resources. We have brilliant people throughout the Caribbean. Why aren't we doing more there? Those are my thoughts.
Sure. Check. Any more questions here? Or any questions online? Any online questions? Still open for maybe 2 minutes for questions. I think we're actually ahead of schedule somewhat. Check 1, 2, 3. Well, Ms. Dunn, I have one for you. And you might have said it before, but what is, I guess your approach or your suggestion regarding supplements? What is your advice to young athletes, especially regarding nutritional supplements?
All right, we at JICO and the World Anti-Doping Agency do not recommend the use of supplements by any athlete, and that is because it can be cross-contaminated And with that, that can result in an adverse analytical finding. That's a positive drug test. And the athlete might be sanctioned for that.
Check 1,
So
2,
we
3.
recommend using
Check
whole
1.
foods. And I'm sure there's a presenter today that will mention a little bit more on stressing that information.
Check 1, 2, 3.
All right, thank you. All right, so if there are no questions here from the floor or online, I think we can maybe close the first session. All right, just a quick mention of sponsors again. Suppligen, DT Physiotherapy Limited, whom we hear from the CEO later on. The Sports Development Foundation, Indus Pharma Company Limited, Medi Wellness, and also just a quick shout to Miss Mercado. Miss Lauren De Mercado. She did a floor arrangements. I just want to give her a big up.
Good afternoon again, everybody. Thank you for sticking with us through the first session. I hope it was edifying and beneficial to you. I would like to, on behalf of the NPAJ, make some quick presentations to our presenters. It's done? I would like to, on behalf of all of our sponsors, on behalf of all of our sponsors, and with the gratitude of NPAJ and the UWI Physiotherapy School or Clinic, just say thank you so much for a very good and edifying presentation. We welcome your support and we thank you for being here today. Yes. Miss Claire Ann Brown, Miss Claire Ann and I are schoolmates. Notice I didn't say old schoolmates. We are schoolmates, and I have known her and I know her, the quality of her work, and she never disappoints. Thank you so much. NPAJ and all the sponsors would like to thank you. Thank you. Dr. Jones. When we started planning this conference, I made one call to Dr. Jones. I don't remember which part of the world he was. And without even thinking too seriously, he said, I'm on board. So I want to thank you. You're always somebody who, whenever you present, it gives you cause for pause and gives you some very important information. Some of which you can use, some I can't really use, but okay. Thank you so much, and coming from all the way in Manchester. Thank you for coming from Manchester. So the sponsors, the NPAJ, the School of Physiotherapy Clinic at UWI would like to give you our thanks for your presentation.
Yeah, check 1.
I'll go this way. Thank you, Dr. Jones.
Thank you very much.
And Dr. Jones, before you run away, I know you're planning to run away. We have a very short simulation, just one, that I would like you to champion the cause for us. Thank you so much for agreeing.
All right, everyone, thank you again. Just a minor correction. So one of our sponsors is not the School of Physical Therapy, but the Faculty of Sport at UWI. Minor correction, they tend to get mixed up sometimes. All right? So with that said, we end our first session. We're going to take a short break, I think 25 minutes, 30 minutes, and we'll start the second session. Thank you again. All right, oh, so our break is at the back. Meal will be served, and then we'll come back later on. What time is it now? It's about 3:15. So we can start by 3:45.
So I would just like to get your attention for a few minutes. We have a few simulation exercises. We'd like Dr. Jones to just champion this one based on what you have already learned. This is a situation. Miss Burke? So we have a young national gymnast. She is 17 years old, and she has just qualified for the upcoming World Championships. She lives at home with her mother, her 15-year-old sister, her 10-year-old brother, and gymnastics is her life. She trains 12 to 14 hours per day, 6 days a week. Somewhere in between. The family is experiencing financial challenges as the cost of supporting Patricia's training is high. Her sister has just passed 7 CXC subjects but wants to pursue more to expand her career options. Her younger brother is about to enter high school. Patricia's coach is exuberant and highly motivating, often saying, "Pat, you can medal, you know." Her main competitor and personal rival is a 14-year-old gymnast whom she has faced on the world stage before. Patricia's ultimate goal is to win a medal for her country and, of course, to beat the 14-year-old. Recently, Pat has been experiencing lower leg pain. It has become significantly worse over time and now interferes with her movement. Although the pain isn't temporarily relieved by exercise, it returns with increased intensity afterwards. Yesterday, she fell from the high bar during training. She now reports severe pain in her lower limb and is unable to weight bear. She has been brought to your facility for management. So I want you to ruminate on that. This is your 17-year-old gymnast. Ask her whatever questions you want and what are the things you want to throw into the management of this situation. Dr. Jones.
So she's simulating?
She's simulating.
Okay. So what you want? Yeah, I figured that's the start. And so forth. Right. All the other stuff until there. So what you want to do? And any takers, I mean, just from the history alone, any takers as to what is the most likely thing? Leg pain, you said lower leg, so leg pain in athlete who is involved in frequent repetitive activities impacting the legs. What's the most likely diagnosis? Yeah, and the leg pain, most likely what you're thinking. Shin splints or post-medial tibial stress syndrome, right? If you, so very common and kind of taxing to treat. If you, the pathophysiology behind it, that it is believed to really be a periostitis, which is the attachments of the leg, the muscle. So remember that the periosteum lines on the bone, and on the, what attaches to that are the different muscles. The muscles at the back of the leg that come off of there, in particular tibialis posterior You have some strong anti-gravity muscles that come off from behind there. And the whole thought process is that in the repetitive activity, you get it pulling on the periosteum. Every once in a while, you might get a small lift to the periosteum and a small amount of bleeding. It's not a big deal. It happens once or twice. But it's like if you have a cut and you have a scab, you know, and it kind of heats up and dries, and you keep picking at the scab, the cut gets much more magnified. I remember that bleeding is the start of all inflammation. So if you keep aggravating that, you amplify the inflammatory process. So the problem really becomes pain, you know, so which, and the whole ideas of how best to go about controlling the pain. No, she never had any treatment, anything done before she had that episode where she fell, and then you can walk on it now. Right, so she fell and now she can't walk on it. So what is the most likely thing that happened from this? So shin splints, the most likely thing that was there. She continued to compete and so forth, then she fell from the uneven bars. Was it uneven bars?
So
yeah, so she fell from the high bar and the uneven bars, landed on her leg. And we've actually seen this happen if you watch it gymnastics, which I have. What is your thought process of what has happened there?
one other spin on that. Could she have some bone stress injury or a bone, some fracture somewhere?
Right. So
A hairline.
So the differential diagnosis of somebody who has medial tibial stress syndrome or shin splints is, do they have a stress fracture? The main difference I've found clinically is that, and this is just based on the whole biomechanics and pathophysiology of the bone. Shin splints, when they occur, you feel them along the posterior border of the tibia, and it's usually extensive. You know, it's usually because that's the extent of where the muscle attached. A stress fracture is usually focal, and usually it involves the anterior border of the tibia. So the tenderness is usually anteriorly. It can be posteriorly, and it's usually focal. So that would be part of the differential diagnosis. Most times in the early stages, if you get like a plain X-ray, the X-ray of the leg is going, that wouldn't show anything. And even if you do like an MRI, it might show you a bone reaction, but there might not be a stress reaction, but there might not be a stress fracture there. Now, the incident that has occurred now, when she fell low and has pain and she can't weight bear, you'd be thinking what? No, you'd be thinking more like, no, she has a stress fracture, which is kind of what happened to this kid with the navicular. He was running, so what you saw on the X-ray there didn't happen at Champs. He had that from before, you know, and then so he ran the 400 heats and did well. He won his heat, I was thinking there. But in the heats and the final, he just couldn't walk on the foot, which made no sense. And when you asked him about history of pain in his foot from before, he didn't really give that. When you see the X-ray, that was going on for months. That wasn't something that happened at Champs, you know. So with this acute episode, we'd have to think that she'd have a stress fracture, you know, and then we would take it from there.
And we're looking at load management. Look at the number of hours that she
Right.
was training. And the
So
number of
in terms of
days.
injury prevention and so forth and thing, most of the injuries that we found in the young athletes, the skeletal immature ones, have been repetitive use type injuries, of which medial tibial stress syndrome is one. And when you have that, how I look at it when they start having repetitive use injuries is that the area has failed. It's unable to cope with the demands that are being made of it. So you have two choices. One, reduce the demand that you're making on the area, that will allow it to heal. Or two, you improve or increase the capacity of that part of the body to deal with the demands that you place on it. And what I've found for shin splints is that the uneven pull of the muscles, the tibialis posterior at the back, that even pull of that with the weak extensors in the front, because you know when you push off, the plantar flexion is very, very, very ballistic, you know, and that muscle pulling on the back of the periosteum is not dampened by much muscles in front, because the extensor muscles tend to be weak. So what I have found, and it worked for me when I was in college, and something I got from the distance runners, is that if you strengthen the muscles in front to improve that balance, so you dampen the effect of the tip bones contracting violently, it helps to prevent the recurrence or the prevalence of shin splints. And that's one of the main. That's one of the main things I've found to treat it. Otherwise, apart from the anti-inflammatory and the rest and so forth. So reduce the load. The 12 how many hours you're training, 16 hours a day. 14. And how old are you? 14? Oh, you're 17. So that's 3 hours less than how old you are. So reduce the load, and then try to increase the body's ability to cope with the repetitive load. That's yes, Angela.
How many days a week should it that?
6.
That's a
6
yeah.
days a week.
Wow.
Yeah, so somebody have to seriously look on that and decide. There's always a balance. We have to look at and decide, we need to back off and then go from there. And just an addition to that, I think part of that whole idea of all these long hours of intense training in a particular sport, a misrepresentation of a paper. Everybody know heard about the 10,000 hour paper. We presented this at one of our keeping pace things, where it talks to become an expert in something, you need to put in 10,000 hours worth of practice. I hear several coaches banting it around and so forth. And the truth, if you read the paper, which I was fortunate enough to, I got the paper and read it. The paper is actually about achieving excellence in playing, a musical instrument. It had nothing to do with sports, But people have adopted this paper from achieving excellence in playing a musical instrument to achieving excellence in sports. And as a result of that, I think what's her name again, Michelle? Patricia. Young Patricia here is probably being loaded more than she needs to be, and somebody needs to really look at that. Is that a question, Johnson?
So, what I was hoping to get out of it is a more holistic picture of the athlete. There's a lot going on. If you notice, there was a lot of her back history where she has this brother and sister at home, and then she's taking up all of the funding for her very superior sport. So then that must weigh on her mind also. She has this competitor which is, at the back of her skull all the time. So we also have to look at her psychological state of mind when all of this is going on. And now she's going to be out of her competition, which is coming up shortly. So it's going to affect her also.
Great. I'm a hammer and nail to orthopedic nails as well. So you have come with the screwdriver part of the flat, so that's great, yeah. So.
Okay. Questions? Okay. So that is just one scenario that we try to show you, that the athlete is more than just muscles and bones and all of that. It is a person, and they're going through a lot of the times. So we have to look on all of them and see how we can best help them. With that said, lunch is ready. It is buffet style, so you can just line up at the back there. And during that time, we will have a presentation from Indus Pharma. Am I correct?
Michelle? I'm worse with me, but I'm not really injured.
Just a reminder as well that we have 3 booths available for you to visit. Our dental health booth right over here, our booth by Indus Pharma. And then at the back, just learn now, we have a dietitian corner JA, which is also here. So that part sponsor, one of the representatives is associated with them, dietitian corner JA. All right, thank you. The restroom is right outside this way, down the corridor, and otherwise. All right, it's now 3:25. We'll meet back in about 5 minutes to 4.
is there. Plus we also have some supplements, and all of them are over the counter. So people who are not heard of those, I just probably my presentation will give an idea of what is this product. By the way, Indus, I-N-D-U-S, which means I and us, we together. I and us is Indus. So we are present in all these Caribbean countries. Of course, we are in Jamaica, we are in Cayman, we are in Bahamas, we are in Turks and Caicos. We also present in Guyana, Barbados, St. Lucia, St. Vincent, all the Caribbean countries, and our brands are available in all these countries. So thanks very much for NPAJ. We have a nice product for pain. There is no sports without pain, right? So we have a wonderful product for pain management. So we know the pain is not everybody, no one likes pain, and the intention is to relieve the pain and to resolve the inflammation and thereby to relax the muscles and bring back the smile. So we have two brands. One is a quick healer and other one is a powerful healer for pain. Let's see which one is the quick healer. The quick healer from Indus Life Sciences Red Heat Spray. So those who have received the bag, you can see inside the bag we have this pain spray, and the interesting information about this pain spray is that this is all natural ingredients. There's no chemicals on it. It extract from plant. It has extract from eucalyptus. It is turpentine oil, methyl salicylate and menthol. So the benefit of this pain spray is that being a spray, the onset of action is quick, within minutes, and we can spray at the area of pain. Whatever pain it is, sports pain or joint pain, back pain, shoulder pain or knee pain, any pain, you can just use this spray. It works amazingly well. It is called as Red Heat. We coined the brand name Red Heat just to communicate any inflammation, the color of the skin changes. And when you touch the inflamed area, you will feel little warmness. Color change, red color, that's why you identify there is an injury or inflammation. Warmness, heat. So when you see red and heat, spray it. That is Red Heat spray. So this is over the counter here, as available in all pharmacies. And the one which you have in your bag, which is 150 ml, it's priced around 850 Jamaican dollars. That's the cost of it. And how many times you can spray is depending on the pain. You can go up to 3 to 4 times a day you can spray it, the Red Heat spray. It has alcohol content is there, so initially little burning will be there, but it doesn't last long, just for few seconds it may stay. After that it will really cool off. So that's our Red Heat spray. So this is a wonderful spray. As you could see the indications, all indications are there. And we have a nice tagline, just like KFC, which says finger looking good. We have a tagline for Red Heat spray. The tagline is powerful like a real beer, safe like a teddy bear. We say it's safe like a teddy bear because the ingredients all natural ingredients. It's very safe. So it's powerful like a real beer, safe like a teddy bear. When you open the cap, the ingredients work like a powerful beer. When you close the cap, a child can hold it. That's why it's called Red Heat spray is available. And apart from this Red Heat spray, pain spray, we have the other one, which is the powerful healer. Why we call as powerful healer? Because this is a gel and the ingredients are very, very, very powerful. Let's just give that. It's Capsitop. I think it is there in your bag. This is our Capsitop gel. Again, this is also over the counter. You can just pick it up from the pharmacies wherever you are from. The ingredients in this are very interesting. The first ingredient is capsaicin. If you could see that, you could read it as capsaicin. What is capsaicin? Is nothing but extract from cayenne pepper, capsicum. Capsicum is extracted from the pepper, cayenne pepper. And how it is useful is very interesting. It depletes, inhibits pain by inhibiting a mediator known as substance P. When substance P mediator is triggered, pain is perceived. When you inhibit substance P, the pain is depleted. And which inhibits substance P? Capsaicin. That inhibits the substance P. So the next ingredient is diclofenac. Medical doctors all know that. Diclofenac is a powerful pain reliever. It blocks the mediator prostaglandin, thereby it relieves pain or inhibits pain. And it has methyl salicylate, which is also found to be useful to inhibit the other mediator as IL-1, IL-2. So it has three active drugs. One is the capsaicin, which is extracted from pepper. The other one is diclofenac. The third one is methyl salicylate. And also it has menthol on it. So this is also one of the powerful pain gel. This is a gel. The Reddit is a spray and Capsitop is a gel. When you use Capsitop, a little caution is advised. As I mentioned, the first ingredient in this is pepper extract. Please do not rub or massage like general gel. Normal tendency for any gel will keep rubbing it or massaging it. We don't recommend to do that because it has pepper extract on it. And of course, other caution, please wash your hands thoroughly with soap. By any mistake, don't touch your eyes or any private parts, it will burn. So that's the only caution with Capsitop. How many times you can apply? Again, 2 to 3 times depending on the pain. We call this a powerful because the ingredients diclofenac and the capsaicin works on the nerves. It inhibits the nerve pain also. The capsaicin approved by US FDA. The capsaicin is approved by US FDA for nerve pain too. Like those who are chronic pain like arthritis pain, this is a wonderful gel. How you can use? Probably daytime when you are at work, it's very convenient to use the spray. When you retire to bed, that time you can apply the gel, as I said, very gently. That's why I always tell my wife, honey, apply it when you are in love. After marriage, she become aggressive. So always remind her, whenever I ask her to apply it, please do it when you are in love. So that's how Capsitop should be applied, gently. Okay, and this tube is actual size. You will get it in the pharmacies, which is priced around $850 to $900 for this tube of 30 gram. That's our Capsitop. Because diclofenac, many of them know. Capsaicin, a lot of them not heard about it. So a lot of studies are available, French studies available, German studies available. Of course, approved by US FDA. You could see the US FDA emblem, which is approved for capsaicin, for topical. And where you can use it, is it back pain, neck pain, joint pain? Honest answer is all the above pain. You can use it for joint pain, back pain, shoulder pain, knee pain. Only pain we don't recommend Capsitop is heart pain. We don't recommend Capsitop for heart pain. Rest all pain, you can use Capsitop. And this slide, physiotherapists will appreciate it. Physiotherapists, they love their patients and the patient trusts the physiotherapist. The intruder is the pain. Pain disturbs the relationship. If the physiotherapist or doctors for that matter don't use a proper gel, the patient will look for another doctor or another physiotherapist, which they don't like it, right? So they love the patient and they want the patient to be with them forever. So if you want your patient to be with you forever, choice is Capsitop. Agreed? Yes. And we have one supplement which is ideal for sports people too. So especially sports involves a lot of wound and stuff. For that we need something. We have this big juice we call as Amino Pep. I'm pretty sure many of you must have seen this product. The highlighting of this is that when we talk about supplement, most of us think about vitamins. 8 out of 10 will talk vitamins B1, B2, B6, B12. But a honest supplement is beyond. It does not stop with vitamins. It also should provide protein. And this is the first supplement in Caribbean, which offers 10 essential amino acids. And these amino acids are active form for protein. They build the protein. Just to give an idea, the arginine is an amino acid useful for healing. somebody underwent surgery or they have wound or anything, arginine promotes healing. Histidine promotes hemoglobin production. Lysine is good for kids also. It promotes growth as well as picky eaters. Those are poor appetite, it opens appetite. And phenylalanine is an amino acid good for most of the kids or university students because it's found to improve the memory. To have good grades, phenylalanine will be very useful. Tryptophan is useful for everybody, especially for sports people, because their stress level is very high, especially before the event. They definitely want to perform well, so that stress will be very high. Tryptophan is referred as stress buster amino acid. If you take tryptophan, your stress is reduced. So that's the benefit of tryptophan. Plus it has all vitamins, vitamin A, vitamin D, B1, B2, B6, B12, vitamin E, vitamin C, calcium is there. It has zinc, which is immunity booster, promotes immunity, 50 milligram is there. So I could say this is the most comprehensive formula. There is nothing, no steroids on it, so it's very safe for athletes too. Especially people play chess, it's really useful for them because of phenylalanine, which promotes memory. That's the reason. And as I said, tryptophan is good for stress, right? Reduces stress. That's the reason before going home, every day I take 10 ml amino pep before entering my house. So it makes me calm. Whatever my wife nags me, it doesn't bother me. At the same time, I don't recommend amino pep to my wife. You know why? Because of phenylalanine. It improves memory. If my wife takes it, she remembers all bad things 10 years before I have not celebrated her birthday. She remembers that. If she takes, she goes 20 years back. So I hide amino pep from my wife, but I'll take it. But I don't think so. You're all in the same scenario like me. You can take it. You can give it to your partner. Okay, so this is good for elderly people. It improves the condition called as sarcopenia, which means as the person becomes old, the muscles become soft like sponge. People become 60, 70, 80, their mobility is affected. They slow down, walking, everything. When you take amino pep, it builds your muscles and improves your walking performance. For a person like a 70 years person who can climb one floor, if they take amino pep, they can attempt a second floor. That's the benefit of amino pep. And this indicates who all can take it. 2 years and above is good. Less than 2 years, mother's milk is best. About 2 years, you can take amino pep. How much you can take? For adults, 10 ml per day at bedtime is good. For kids, 5 ml is enough per day. Okay, and people who underwent surgery or chemotherapy or those C19, which are called immunocompromised people, for them nothing wrong going up to 15 mils 2 times a day. But normal person, 10 ml at bedtime is good. It's sweet, it's a chocolate caramel flavor, but there's no natural sugar in it. So diabetes patient can take it. It's a sugar substitute is there. So you can take it safely. People who are in, those sugar bags are full, who refer as diabetes patients, they can take amino pep too. So this is the dosage, and there are many supplements. You can see which stands tall. And we have a lot of responsibility for the community. This year we distributed more than 2,500 back to school bags to the school kids in Jamaica. So we plan to do more in coming years. So for amino pep, we have been doing this activity. So the last product which I like to end today is for persons who have, this again over the counter product, who often have acidity, gas problem, acid reflux, heartburn. We have a wonderful antacid. You all know a lot of brands of antacids in Jamaica, right? And they are all good brands. I'm not bashing them, but this is something novel. This is the first time we have introduced an antacid from Indus known as New Gel. It has a unique ingredient you could see in the screen, alginic acid, ALGINIC, alginic acid, which no other antacid currently in Caribbean has that. What is the benefit of alginic acid is very interesting. This alginic acid, when you take this antacid, forms a foam, as you could see in the screen, a white raft called as alginate raft. It prevents acid reflux. People after dinner, you lie down, it throws up, and it causes, a burning sensation in the chest. When you take this antacid new gel, you don't encounter that. So this is because of alginic acid. It's a natural algae which is there in new gel. And what is it? Unfortunately, this clip is not running. Is okay. Is okay. So this has regular other medications like aluminum hydroxide, magnesium hydroxide, which neutralize acidity, and it has dimethicone, which is basically relieves gas, and it's safe in any age group, including pregnant mothers can take it. It is good for acidity, gas problem, acid reflux, and heartburn. We also have extension of this, which is also over the counter, which has additionally the O, oxytocin. You could see it, which is highlighted in red. Oxytocin, which is anesthetic drug, means it relieves pain. So people have acidity pain, gastritis pain, ulcer pain, stomach pain. When you take this antacid, it relieves within less than 5 minutes. It is also known as 5 minutes miracle antacid new gel O. This is also over the counter. The difference between the new gel and new gel O is that the one in the purple pack, new gel, is safe in pregnancy, but this one, the O, is not recommended during pregnancy, and also kids less than 12 years. Non-pregnant mothers and whoever is about 12 years, this is the best antacid. For acidity, gas problem, acid reflux, heartburn, it is recommended. So this is an indication of new gel and new gel O. So we have it in sachets, we have 200 ml, and we also have 100 ml. So that's it. If you need any samples, you note down this WhatsApp number. Just WhatsApp to us. We'll deliver the samples to you. Thank you very much. Enjoy the rest of the program. Thank you. Good day.
Welcome to our afternoon session. I hope everybody is enjoying all of the proceedings thus far. And I noticed none of you are going to ask about anything related to dental health. So I'm going to afford our young dentists, Dr. Brian and Dr. Burke, to come up for 5 minutes to just tell us the importance of dental health in sports medicine. Please make them welcome. Thank you, Dr. Brand.
Good afternoon, everybody. I've been noticing that we haven't had much interactive sessions this evening, so this one will be quite interactive for us. So we can learn something quick and fast, all right? So I'm not sure if there are some flyers that have been given out, but there should be some flyers that are giving out about dental health. Quickly, first, if you notice on the flyer, it said that you should visit your dentist every 6 months. Can anyone explain to me or tell me why it's important to have regular dental checkups? Yes, early detection of problems, very important. Is there anything else? It's just very good to have maintain the state of oral health, all right? Let's talk about the diet. How important is it for us to eat foods that are good for our teeth? It's very important, right? There are some foods that we'd like to mention. Foods like dairy, foods like fruits and vegetables. These are very important for our teeth, right?
Not just the foods that are good, but also the foods that are bad. I know a lot of people like to chew bone, and we crack teeth, break teeth, things like that. Chewing of bone and ice is absolutely prohibited, right? We don't want to do that. Also, things that are super acidic, June plums, oranges, grapefruits, things like that. Of course, you can have them, but everything in moderation, right? Because acid is what causes cavities. The acid burns holes into your teeth, they get very weak, and you end up with cavities, broken teeth, fractures, all kinds of things. So you want to avoid super acidic foods, go for your crunchy, leafy vegetables, and calcium-rich foods.
So on the flyer, we're skipping the mouthguard section for last. We're keeping it last. But there, we should brush and floss every day. We should brush twice a day, and we're flossing at least once a day. It's also important to try to floss before brushing. Flossing before brushing helps to loosen up those particles between the teeth, so the brush can do the rest of the movement, right? It's also very important to note on the flyer where you can get your next appointment. I'm not sure how much I'll be paid for this, but it's very important to check this dental office for your next appointment. Let's go over to the mouth guards. Mouth guards is very important when doing contact sports especially, but sports in general. There are different types of mouth guards.
Yeah, there are different kinds of mouth guards. There's stock mouth guards, which are the cheapest, but obviously not the best. Everything has its advantages and disadvantages, right? So stock mouth guards will run athletes about 15 to 30 US dollars. And as you can imagine, they're stock. So they come in a general shape, you pop it in your mouth and you go and play, right? But obviously everybody is different, every athlete is different. So what works for one might not work for the other. You have...
For the stock mouth guards, most times it's advised to get one of those as maybe like a temporary treatment until you can get a custom mouth guard. We'll get into custom mouth guards now.
Right, so there's semi-custom, which is, we call them boil and bite. So you order it, it's a material, and when you heat it or boil it, it becomes a little bit malleable. So you boil it and then you bite on it and it shapes to your teeth, right? However, that's still not ideal because it's not gonna get the proper contours of your mouth like if you were to go and get it custom made. So the one that we're pushing for, the best one obviously, is the custom made mouth guard. And in that case, you will go into a dental office, they'll take an impression and create an exact replica of your mouth. And from that, we can fabricate a mouth guard for you or for the patient. So we have some examples of mouth guards here. I have one here, there's another one on the desk. And you can see what they do. You can see the difference in two different patients. So one is not gonna fit everybody. Right. So it shows the importance of getting it custom made. There's also a slideshow there that's consistently playing with just some more information on what we've talked about here, a little deeper of an explanation. And yeah, thank you for listening.
Thank you very much, Dr. Brian and Dr. Burke. So now we're going to move on to the second session. I would like to introduce Dr. Ramon Hunter as our moderator for session 2. He's a doctor of physical therapy, registered sports physiotherapist, and head of the UWI Sports Medicine Clinic, the section of sports and exercise medicine, Mona Academy of Sport, Faculty of Sport. I really did not know the name was so long. Okay, Dr. Hunter, thank you.
Thank you. So we'll be going into our next presentation. The title is Fueling Strength, Innovative Nutrition Approaches for Powerlifters. And this will be done by Mr. Alex Johnson. Mr. Alex Johnson is a clinical dietitian, a nutrition professional with experience across hospital, community, and sports settings. He holds a Bachelor of Science and Postgraduate Diploma in Dietetics and Nutrition from the University of Technology, Jamaica, and is currently pursuing a Master's of Public Health at the University of the West Indies. As founder of Dietitian Corner Jamaica, he focuses on innovative nutrition strategies for athletes and is passionate about performance nutrition, gerontology, and advancing public health. Please welcome Mr. Alex Johnson.
Hello, hello, hello. All right, so we're going to do a quick stretch, quick stretch. We're going to spell coconut. We just eat, so we need to warm up ourselves. So I'm going to do the example and show you. Hold on. So we're going to do C-O-C-O-N-U-T. All right, so we have to stand. You have to stand. Ready, ready. Yes, man. We are all physical therapy and nutrition and health people, so you can't be crinked up. We need to loosen the bones, all right? So let's do it together. After 2, 1, 2. C-O-C-O-N-U-T. Let's do it a little faster. C-O-C-O-N-U-T. All right, all right. Good, good, good. We're warmed up. All right. So we're ready to go to the did that warm you up? All right, good. Okay. Let's get into our presentation. Okay, good. First, next slide. Oh, I control it here. What do I do? Oh, green. Praise God. All right. All right, so the main objective today for my presentation is to highlight the innovative, practical, and culturally relevant nutrition strategies that optimize power, recovery, and longevity in the sport. And my key message today, let's read this together. Strength isn't built in the gym alone. It is fueled at the... All right, so by the end of this presentation, we'll understand why is it that strength is fueled at the table. Next slide, please. Oh, me. Oh. All right, so the power of fueling right. So powerlifting is a sport of explosive strength, precision, and discipline. While training intensity and techniques are critical, nutrition determines how well the body adapts, recovers, and performs. So, the science of strength nutrition. So, the energy demands of powerlifters, unlike endurance athletes, powerlifters rely primarily on, oh God, let me start over. Unlike endurance athletes, powerlifters rely primarily on phosphagen and anaerobic systems for energy. I'm going to read from this screen. My phone screen is too small. For energy bursts lasting seconds. So, energy balance is key. We need to understand that too little equal muscle breakdown. We're having a discussion earlier with Dr. Burke and Dr. Mandra Singh, correct? Mansingh, praise God. All right. So we were talking about the athletes not having their proper nourishment during their track meets. So too little, if you're not having enough energy, what is going to happen is that the muscle is going to break down. And we can go into the biochemistry and all of that. Why is it that we're going to have a breakdown? Then too much, so you see we have to strike the balance. So too little equal breakdown, and too much gives what we call unwanted fat gain. Bless the Lord. Unwanted fat gain. So chronic low energy intake leads to what we call relative energy deficiency in sports, and which impairs strength, recovery, and hormone function. Now, we cannot have the discussion of recovery and don't speak about nutrition. Nutrition is of paramount importance when we are talking about recovery, and we're going to see why in our slides. So this is just showing you the process from blood glucose, the muscle glycogen, into glucose. We have our ATP, and we have our aerobic respiration and our lactic acid to the blood. All right, so let's talk about our macronutrients. So there are 3 macronutrients we're going to focus on. Let's say them together. So protein is the, all right. Carbohydrate is the fuel, and fats is the hormone regulator. So we need protein because protein, the ideal intake is 1.6 to 2.2 grams per kg. Now, as dietitians, we do not give people a bunch of things. We give them according to their body weight. What is required of that patient's body weight. And for our physiotherapists that are present, you know the importance of personalized treatment. This Google era that we are in, where some practitioners go on Google and give nutrition information to our athletes specifically, is wrong. Because what they are doing, they are giving them recommendations for a general population and not focused to the athlete's specific needs. So you can't be managing a power lifter the same way you're managing a swimmer. Come on now. Wanna work with me now so I can finish early? Yes, I'm a preacher, so you have to sit with me, you have to work with me. So we have to ensure that we spread the intake throughout the day. We're not going to have all our protein in one sitting. Now, I just want to big up Dr. Burke for that lunch today. It was perfect. We had a clapper, man, clapper, yes. Because many times I go to these health functions and these medical conferences and the food doesn't match what they are preaching. Now you want to ensure that you have a balanced protein intake throughout the day. We're going to talk about the dangers of having too much protein. That's something that we are not stressing enough, and that's something that is a real issue. So we're going to talk about that. Now for the carbohydrates, they are required for glycogen storage and explosive lifts, and low carb diets reduce training intensity and delay recovery. So all these people are telling our athletes to cut out carbs and to eat a bunch of protein. That's incorrect. You need carbohydrates, which in turns turn into glucose, as that is your body's main source of energy. But we know about ketosis and all of the other pathways that can happen when the body does not have the right amount of glucose. Now, let's list some of the places we can get our carbs from. So our yams, that we don't like to talk about, which is very good fuel for our athletes, or green banana, breadfruit, or plantain, or rice, and our oats. Now, for the fat, the hormone regulator, these support testosterone, joint lubrication, and vitamin absorption. So we want to encourage our avocado, or nuts, or seeds, or coconuts, or olive oil, or ackee, etc. as our fat sources. Why this looks so small? Can you zoom in, Mr.? Oh, you can't zoom. Okay, it was bigger on my screen. All right, so we have our macronutrient breakdown. As we said earlier, we want to do 4 to 6 grams per kg for our carbohydrates. As I said earlier, everything must be done per patient. So it cannot be that the coach uses a meal plan for the entire team. It happens where coaches do one meal plan or get one nutrition consult and the entire team eats the same way, which is ridiculous. They get an exercise program and the entire team exercises the same way. We have to move away from this type of management. So something that we don't talk about enough is our micronutrients. And micro mean small, so we need them in smaller quantities. So our iron, we have an iron deficiency problem. A lot of our 13 to 18-year-old females, especially school-age children, are what we call iron deficient. They are not getting enough iron-rich foods. They're not eating their callaloo. They're not having their spinach, their pak choy, their green leafy vegetables. We're cutting that out. So we need to encourage our iron-rich foods. Our magnesium and zinc. I'm sure every physiotherapist here have recommended magnesium supplements at some point. So we know that magnesium and zinc aids in recovery, protein synthesis, and immune function. Very important. Then we have our vitamin D and calcium. Our body needs vitamin D and calcium for bone and muscle strength, especially relevant for indoor training. And we know why indoor training, because if they are not in the sun, they're not receiving the vitamin D. All right, so hydration. Now, this is another problem that we have. Our athletes, many times, when they come to the injury booths, Auntie Perrin can tell you about that, many times they are dehydrated. So they are not properly hydrated throughout the period of training and during their athletic performance. They are not properly hydrated. So what does hydration look like? So hydration is often overlooked, especially in powerlifting. You may not think that you're doing too much physical activity per se. You're not running or skipping or hopping as the field and the track and field athletes would do. But you still need to have water, because 1 to 2% loss of body weight from fluid loss can impair your strength, your focus, and your recovery. So as a gerontologist, I do see many times the older adults coming in and they have what they call the acute confusion. Many times that acute confusion that we like to call dementia is really dehydration. So hydration is very important for all levels, from pediatric to geriatric. We need to be improving on our hydration. Proper hydration maintains muscle contraction efficiency. A lot of people ball for muscle contract. Many times they check it out, they are dehydrated. So we want to ensure joint lubrication, cardiovascular stability, nerve signaling, and very important in our Jamaican setting, thermoregulation, so critical in your tropical climates. I don't know, something is wrong. It's cutting off my tables, but let's move on. So if you lose 1 kg during a session, drink at least 1.5 liters of water or electrolyte mix afterwards. So it sounds crazy, but in total, when you look at all the body fluids that you're losing, you need to be replacing your loss of fluids, because we know once there's output, we have to replace. So when the patient is losing water, and in this case the athlete is losing water during exercise, we want to encourage hydration. And I see everybody here drinking from their bottles or your cups, which is important. Even though you're there sitting down, you're losing water. You're sweating, different things like that, so it's good to keep hydrated. For your electrolytes, we want to ensure that we're having our sodium, our potassium, and our magnesium. Electrolytes are important. These prevent muscle cramps and support fluid balance, aid in nerve and muscle function, and reduce fatigue and improve muscle contraction. All right, so let's look at some approaches, some practical stuff that we can do. I like to make stuff relatable. So we go through all of the fancy talking now. We're going to look at relatable practical approaches when we are dealing with nutrition. So we want to look at our periodized nutrition. So we want to tailor the intake to training cycles. So your off season, which is our hypertrophic phase, we want to have slight caloric surplus, and we want higher carbs and protein for muscle growth. Then for our strength phase, we want to maintain high protein, and you want to moderate carbs. So we never say low carbs. We say moderate carbs. And we want to focus on meal timing around the training. So you want to ensure that you're eating in your correct timing. And that's why it's important to get a consult from a dietitian or a nutrition professional when you're taking on these strength trainings, athletic journeys. It's very important. During your competition don't mean you go on fasting. So competition time is not time for prayer and fasting. and you go on this long everlasting fast in preparation. When it's competition time, you want gradual, strategic caloric adjustments to maintain lean mass while optimizing your weight class. And everybody's body type is different. Remember, so some persons, their body type is a little bigger than some. So for them, their normal weight will not be your normal weight. So we have to get this idea out our minds that persons have to be skinny to be healthy. We want to ensure that persons are the best version of their body type. That's what we promote in nutrition. Now, another thing, what is gut health doing in a sports presentation? Now, a thing that we have neglected because of this whole heap of antibiotics that we take, every time we go to the doctor, we get antibiotics many times. So we want to encourage persons to have their probiotics and prebiotics. Now, your gut health is important. If your gut is sterile, if the gut bacteria is all gone, you're going to have a sick tummy, because you need that gut bacteria to help with digestion. So a healthy gut improves nutrient absorption, it reduces inflammation, and it supports immunity. Yes, something as simple as your gut being healthy. And I know it is a big discussion now in gastroenterology. A lot of persons are talking about gut health and optimizing gut health. It's something that we need to bring into the sporting arena also. So we have our prebiotic and we have our probiotic. So for the prebiotic, we can get from our onions, our bananas, our oats, garlic and wheat. And our probiotics we get from our yogurt, sauerkraut and kimchi. Now, some people may be saying, we don't have that in Jamaica. Yes, we do. Persons, we can get sauerkraut and we can get kimchi here in Jamaica. All right. So we also need to integrate our Jamaican foods. Eat Jamaican. You can't be a Jamaican athlete and using an American diet. That doesn't make any sense. It happens. Where they get this thing online, or we're using AI now and we pull down a nice fancy thing, and when you put it in practice, it doesn't make any sense for a Jamaican athlete. So we want to encourage our yellow yams, or callaloo, or breadfruits, or ackee. Yellow yam is a complex carbohydrate for long-lasting energy. Our callaloo is rich with iron and calcium. Our breadfruit is a versatile carb alternative. And our ackee, we get our fats from. So now the part that we have been thinking about and waiting for, and my friend from JADCO would have spoken about the nutraceuticals. They are not recommending those to be taken. Now, overconsumption of protein and protein supplements is a serious thing in sports. If you as a regular person go to the gym just to look toned like me and look, with a summer body, the trainer is telling you to take protein sometime twice your body weight. And when you calculate that nitrogen load, you're putting your kidneys at risk. A lot of people don't know this, so they're using every protein powder on the market. They are eating adequate protein intake orally, and they're supplementing, which is ridiculous. So, understanding the myth, many athletes assume more protein equal more muscle, leading to overconsumption, which many times they are having 2.5 to 3 grams per kg per day. Unless you're catabolic, where you have cancer or some form of pathology that will pull so much of your nutrients, you do not need to be taking in so much protein. So, however, the body ability to utilize protein for muscle growth is limited. So the excess is oxidized or excreted. And this is where our Mr. Kidney over here is at risk. So we have to be very careful on the amount of protein that you are taking in, because it can be detrimental to your athlete or to your patient. So, more protein equal more muscle is a, when I call out the myths, I want you to say it loud and strong. So, more protein equal more muscle is a, so the fact is, muscle growth has a biological ceiling. No matter how much protein you eat, or if you pray over the protein and eat it, it's not going to magically give you more muscle. So everything must be done in its right proportion. So we're not saying you must eat protein. Protein is very important, but excess protein does not benefit you in any great way. So protein shakes build muscle faster. Is that? Say it loud for me, please. All right. So total nutrition and training consistency matters most. So you could have drink protein shake till God come. If you're not doing everything holistically, there will be no benefits. High protein increase energy. So supplement, high protein increase energy is all right. So supplement, they don't replace whole foods. Nothing beats eating your whole foods. Unless there is some nutrient malabsorption or some problems with the utilization of the nutrients, you don't need supplementation. So all the people who are taking one bunch of vitamin C, but you're taking in your oranges and your pineapples and stuff, you do not need it unless you're having some form of malabsorption or your body is not utilizing it properly. All right. So the physiological implications, let's listen carefully because we need to evangelize this to persons who are overdoing the protein. So we want to remember that the renal and hepatic stress, so chronic high intake increased nitrogen load, straining the kidneys and the liver. Risk elevated when combined with dehydration or pre-existing conditions. The digestive discomfort, the micronutrient deficiencies, and the supplement contamination risk that our colleague from JADCO would have shared earlier. So we spoke about the evidence-based guidance, and just a practical tip, encourage athletes to do a nutrition assessment with a dietitian every 3 to 4 months to individualize intake based on body composition and training volume. Because if you're training more, you need to change your diet to fit that. And if you're training less, you need to change your diet to fit that. Oh Lord, my beautiful tables, I don't know the system, cut them off. So safe weight management strategies, avoid extreme caloric restriction or dehydration before the competition. Focus on gradual weight adjustment, 0.5 to 1% body weight per week. Use nutrient timing, hydration control, and sleep to maintain strength during cuts. You have to rest. If you don't rest, all of this exercising and body things where you're doing won't benefit you. Your body needs time to rest. Right, my physiotherapists who are here, correct me if I'm wrong now or throw a stone at me. Am I right? You're going to throw a stone at me. All right. Encourage collaboration between the dietitian and coaches for safe pre-competition prep. The coaches, unfortunately, has been working by themselves, and many times they have not been giving adequate information to our athletes. And I would be bold enough to say, because my back is broad, some coaches go as far as being physiotherapists, medical doctors, dietitians, sports psychologists. They do everything that we spend years to train for. So we have to be very careful of that misinformation. So nutrition support not just the body, but also the mind. So we have to ensure that we have improved focus, recovery, and sleep, and we want to reduce risk of injury and chronic illnesses. So the holistic approach aligns with Jamaica's national treasures theme, building athletes who are strong, healthy, and sustainable. Many athletes start and they never reach to their prime because they were not properly nourished, they were not properly supported, and we want to cut that out, as Dr. Brown presented earlier. That's his name? Brown? Huh? Brown, yes. Dr. Brown spoke at length about, forgive me, I'm bad with names. He spoke at length about setting up the system. So we need that system. Jones, Lord have mercy, Dr. Jones. All right, long-term career preservation. So some athletes only have a short window of time where they are great. Injuries knock them out, and why they are injured, they are malnourished. And I use this term very, very intentional. They are poorly nourished, and that leads to injury, and the injury is not properly treated by the right professional. Am I talking the truth? Say amen now. All right, good. So my takeaways today, let's read them together. Nutrition is the foundation of peak. Let's say that again. Nutrition is the foundation of peak. Focus on quality, timing, and local sustainability. Integrate dietitians into coaching teams, and strength equal training plus rest plus nutrition intelligence. Fuel wisely, lift smart, and let food be your foundation for greatness. Thank you, everyone.
Thank you very much, Mr. Johnson. The next presenter will be presenting on the holistic development of the Jamaican athlete. And this will be done by Mr. Desmond Thompson. He's a physiotherapist and Chief Executive Officer of DT Physiotherapy Clinic in Kingston, Jamaica. He holds a Bachelor of Science in Physiotherapy from the University of the West Indies and is currently certified in dry needling and sports taping. A two-time national powerlifter champion himself and national record holder, Mr. Thompson combines clinical expertise with athletic experience to promote holistic athlete development, injury prevention, and rehabilitation in sports medicine practice. Please welcome Mr. Desmond Thompson.
Good afternoon. I hope everybody's doing well. All right, so my name is Desmond Thompson, and today I'll be talking to you on the holistic development of the young Jamaican athlete. Now, a lot of our presenters today spoke about different parts of the holistic development. Now, I'm here to tie it all in with emphasis from my experience from a physiotherapist role. I am highly inclined for professionals, to stay at what we're good at. So I will emphasize from my point of view the physiotherapist role, because as the previous presenter said, you have persons who are taking care of athletes that are going into other realms than what they're specialized in. All right. Hold on. How do I write this thing again? What's that? Is that one? Oh, green. This one? This one? Oh, that one. Okay, all right. And that will come back. All right, cool. All right. So some of the things we will go over is the Jamaican sporting landscape for youth, challenges facing the youth, young athlete, physiotherapy, and the long-term athlete development model. Now, we're going to look at the physiotherapist's physical role, injury prevention and screening, rehabilitation, athlete education and behavior change, collaboration and communication. Then we'll have a brief case study and then the recommendations. All right. So Jamaica has a rich sporting culture. Athletics, track and field, football, netball, and others dominate the school competitions. And our young athletes begin very early. Systems exist for these athletes to go on for international scouting, to go into more professional sports, and also to represent the country nationally. However, as we push for performance, we must ask, do our support system keep pace? Coaching is just one part. We have health, injury prevention, psychological support, lifestyle, and guidance are equally vital to the young athlete. So some of the challenges experienced by our young athletes is one, early specialization and overuse risk. Many youths concentrate on a sport too early, which increases repetitive stress injuries. Now, when we look at that, most of our athletes or our parents can talk about is that their child starts in a sport from about probably prep or primary school, because you have prep champs and all the other competitions there. Now, this is one aspect where a child would be introduced to specialize in that sport too soon. Now, another thing that we have is limited access to allied health. Now, in rural areas or lower resource parishes, physiotherapy, nutrition, and sports medicine may be scarce. We have also the socioeconomic barriers. Athletes may struggle to travel to meets. They may have improper equipment. They might have improper diet or even recovery resources. And there is also a disconnect between training and holistic care. Now, training now focuses narrowly on performance without integrating a health and well-being support system. So now we can say, what is holistic development? Now, holistic development means nurturing the whole athlete, not just their physical body. It means seeing the athlete as more than just a performer. It includes their body, mind, and lifestyle. Now, the ultimate goal isn't just medals. It's building healthy athletes who can sustain performance and wellness throughout their lives. Now, we can look at it and see physically, the athletes need good movement skill and conditioning. Psychologically, they need resilience and motivation. Socially, they benefit from teamwork and leadership. Lifestyle habits like sleep and nutrition are important. And we can see where this holistic, the different categories in holistic development, it encompasses every profession within the realm of the athlete in terms of psychologists, sports medicine doctors, physiotherapists, dietitians, and we can see that everyone fits in a certain category where the athlete is at the center. Now, why does holistic development matter in youth sports? So, holistic development ensures young athletes stay healthy, motivated, adaptable, and it prepares them for long-term success, whether in professional sports or other careers. It builds discipline, resilience, and community values. Now, we can all remember when we're in school, we used to be taught that we need to be a well-rounded individual. Someone that your academics is good, but you also play a sport. Now, because when you play sports, it develops your motivation, not just to do well in the sport, but to do well academically. It keeps you adaptable, and also a healthy mind, a healthy body, right? And not limiting to that, but it also builds this discipline and resilience. Now, this is the LTAD, which stands for the Long-Term Athlete Development Pathway. Now, this pathway was developed by a Dr. Bailey, a Hungarian-Canadian sports scientist. Now, he worked with national teams from Canada, UK, New Zealand, Australia, and he found that there was no set system or structure for athletes to develop an athlete from the younger stages into career-building athletes. So he proposed that there were 7 stages for the LTAD model. Now, here's what we can, hold on, let's get into this. Yes. So he proposed that there are 7 stages. We have the active start, we have the fundamentals, the learn to train, the train to train, the train to compete, train to win, and active for life. Now, he developed this because he realized that coaches and federations were often treating children like miniature adults, where they overemphasize competition instead of development. They train without consideration for maturity or growth stages, which cause early burnouts, overuse injuries, and eventually early dropouts. And they relied on early specialization, even in sports that required long-term development. So when he analyzed these athletes over multiple Olympic cycles, he identified their success was linked to timing, growth stages, and progressive training, not just their talent and effort. Right? And his research highlighted the importance of their biological age, not just their chronological age, especially during their peak height velocity, which is their growth spurt. Now, he formalized these, as I said, into the 7 stages that we see here. Now, the physiotherapist role spans all stages, and we support physical literacy, movement competency, and healthy development. So here we can see the active start is from 0 to 6 years, where we have infants and young children. And here the physiotherapist's key role is to promote physical literacy through basic movements, where we educate patients on safe physical activity and address any developmental or motor delays. Now, the fundamental stage, which is the early school age, 6 to 9 years. It assesses movement patterns and coordination, promotes safe play and motor skill development, introduce injury prevention through play-based exercises. Now, here is the learn to train, the 9 to 12 years, the pre-adolescent years. And this is where we screen for growth-related risk. Example, Severs and Osgood Shattlers, which is, and where we do a designed prehab program where we work on their overall care, the balance, the flexibility. We educate on body awareness, warm up and cool down routines. We have the train to train, 12 to 16 years, the adolescent years, where we manage growth spurts and injury risk assessments. So, example, overuse injuries. We provide structured rehab and recovery programs and teach load management and correct technique, and collaborate with strength and conditioning coaches for safe conditioning. We have the train to compete, 16 to 18 years. Late adolescence, where we address sports-specific demands and performance needs. We implement surveillance systems, support mental recovery, especially during injury setbacks, and offer return to play assessments. Now, we can all see that most of our athletes don't make it to the learn to compete. And most of our, even more, majority of our athletes don't make it to the train to win, which is 18 plus years, which is where we provide advanced rehab performance enhancement, ensure optimal movement efficiency, biomechanics, use data to guide training load decisions, and monitor chronic injuries and tissue health. And then now we have the active for life, which is at any age. This is where we support the transition from competitive to recreation, manage chronic or past injuries, encourage lifelong physical activity and function. And here in Jamaica, due to reasons previously mentioned, a lot of our athletes reach active for life before they even reach train to compete. A lot of our athletes, due to injuries, they don't make it that far in the sporting world. So our physical role as physiotherapists, now we look at injury prevention through screening and load management. And this is where, when we look at the learn to train phase, the 6 to 9. Now, when we look at that now, the movement analysis to improve biomechanics, this is where we teach the young athletes. Once we assess each athlete, we will look at it and say, hey, this athlete has flat foot. We look at their, if they have genia valgus or genia valgus, we look at all of their anatomical issues or all their muscular issues. Some athletes might even have a mild scoliosis. So we look at their overall biomechanics, and then we will collaborate with other persons to tailor the best management for this athlete. Right? So there's strength and flexibility programs tailored for youth, recovery protocols such as massage, cryotherapy, stretching, such as and other modalities, promoting proper warm-up and cool-down routines. Now, we have the pre-participation screening to identify high-risk athletes. So here we'll look at tracking their HPV, their PHV, their peak height velocity, during their growth spurts, which is where a lot of overuse injuries, shin splints, based on their sport that they're doing, we see a lot of injuries because this is the time where coaches push the athlete or push their body further than what their body is developed to do. So the muscles, the tendons, they don't keep up, or they have not adapted to their new height as they're growing. Now, here we can also design and implement injury prevention programs such as the FIFA 11, the plyometrics, which will help to strengthen the athlete at the stage that they're at, and provide ongoing education for not just the athlete, but the coaches and the parents when it comes on to load management, intensity, and frequency. And here we have also rehabilitation. Now, a lot of time rehabilitation, when they're not professionally guided, they use a time-based approach, saying, oh, it's been 4 weeks, 4 months, the athlete can probably do this or that. It's not a criteria-based progression. And this, as medical professionals, this is what we do, where we focus on a criteria-based progression and not just a time-based progression. And then also we have objective strength and function benchmarks and not just baseline contralaterals, meaning an athlete that has been injured, we don't just say, oh, this leg is as strong as the next leg. The athlete is good to perform. No, we have the objective strength and the functional benchmarks that we would use to then guide the rehabilitation of the athlete. We have sport-specific skill exposure and fatigue testing, graduated training participation with clear communication, and also for psychological readiness, assessed and supported. So this is where we will know in the rehab process. Now we can rehab an athlete physically, but then the psychological portion we'd have to refer to the sports psychiatrist to see if this athlete is ready to perform. Because you can see that, you can appreciate that malingering in a sport it's possible. An athlete may be feeling psychological pain that they are thinking it's physical. So, as physiotherapists, we're often one of the first to notice any signs of emotional stress. Now, this is due to the frequency that we will see in a young athlete. So, a once driven athlete who's suddenly disengaged, fatigued, or inconsistent, right? So now by fostering trust and open communication, we can create an environment where young athletes feel safe to talk. Our role extends beyond just physical recovery. It's about recognizing mental fatigue, which impacts performance and guides them toward the right mental health support. Teaching mind-body awareness reinforces focus, resilience, and overall well-being. So, from a physio perspective, this is where we can recognize stress, anxiety, and burnout. We can also use confidence-building rehab strategies. This is where we set up our athletes to boost their confidence. We will give them exercises or programs which are tailored for them to win, tailored for them to succeed. And also, when it comes on to their mental status, then we'll refer them to the mental health professionals. Now, our role in education and behavior. Now, education is one of the strongest tools. We guide athletes on proper body mechanics, recovery, and importance of rest. We also work closely with coaches and parents to create a supportive environment that reduces risk and promotes growth. Now, in this age of technology, we have WhatsApp, we have many forms of communication in which we can reach an athlete, whether directly or indirectly, where we can educate them or keep track of them, where we can educate them on not just their sleep, but to follow up with their exercises, to follow up with certain things that we would educate them not to do. We can have parent sessions where we can educate the parent that, you know, your child is going through this growth spurt. So we can educate them on any pain the child may feel, load, ensure that they get proper sleep, and also the basics of nutrition. We can have workshops with the coaches where we can inform them of proper warm-ups, workload tracking, and any red flags. And also for the athlete themselves, we can go through goal setting with the athlete and celebrate the process and not just the results. Now, as a communicator, we can be a link between the athlete, the family, the coach, and the medical doctors. And now we drive integrated care and decision making and support. One of the ways we can do is to support documentation and continuity in the athlete's record, because no single professional can develop an athlete fully. We work in collaboration with everyone to ensure every aspect of the athlete's well-being is covered, from diet to mental health to recovery. And now we have a briefcase where patient X, 16 years old, who is a 100 and 200 meter sprinter, train load 6 days per week, and the goal is to qualify for the ISA Boys and Girls Champs. Now, the initial presentation, oh no, this is a male. On the initial presentation, the gradual onset of right hamstring tightness and pain during sprint training for 3 weeks, had a mild limp and discomfort on the acceleration phase, no previous injuries, and the psychological state is anxious, worried about missing champs. Subjective finding. Pain during mid-swing phase of the sprint, reports increased soreness after gym sessions, limited hamstring flexibility. On objective findings, patient had a grade 1 hamstring strain, weakness in glute maximus and core stability, poor hip mobility and altered running mechanics, psychological stress, and poor sleep due to competition anxiety. Now, for the physio, we have during the acute phase, we focus on pain-free range of motion, soft tissue mobilization, and education on the load management. The subacute phase will progress to eccentric loading, core and glute activation, strength and mobility drills, and also stationary bike and pool training. The functional phase, where we focus on the sport-specific drills, sprint mechanics, resisted runs, plyometric training, and then gradual reintroduction into sprint under supervision. Now, for the psychological support, we'd collaborate with the psychologists for stress scoping strategies for performance anxiety, visualization and mindfulness sessions, motivation reinforcement during recovery. For the nutritional guidance, we'll refer to the sports nutritionist for optimizing protein and micronutrient intake, recovery, hydration, and timing of meals. For the education and athlete empowerment, injury prevention workshops, so proper warm-up, recovery routines, and sleep hygiene. Self-management plans, so we teach them on foam rolling, stretching, recovery tracking, and then we'll talk to the patient, the parent, and the coach for training load coordination and communication. So the long-term athlete development integration. So we focus on building a foundation of resilience and peak performance. So key physiotherapy contributions would be baseline musculoskeletal screenings, periodic movement assessment, monitoring growth and peak height velocity changes, injury data tracking for future prevention. Now, for the return to play criteria, so he was cleared after 6 weeks based on pain-free full sprinting, symmetrical hamstring strength, negative clinical test for strain, psychological readiness assessment. For the return to play plan, it was gradual progression to full sprint sessions, then competitive drills, then a mock race, and then the champs competition. Now, the key takeaways: the physiotherapist's role in the physical aspect of the holistic development. For the physical, we have the assessment, the rehab, the biomechanics, and the return to play. For the psychological development of the athlete, there is motivation, stress management, and the collaboration with the psychologist. For nutritional, there's the education and the coordination with dietitian. For the social environment, we liaison with the parents, the coach, and the support team. And for performance, we do the screening, the injury prevention, and the integration into the long-term athlete development. So, what does holistic success look like? So, holistic success is about producing not just successful athletes, but well-rounded human beings. When we talk about the whole athlete, we mean a person who performs confidently, manages setbacks with maturity, and understands balance in all aspects of life, from training to academics to personal well-being. Now, as physiotherapists, our goal is to guide this balance by integrating physical training, mental resilience, and education on recovery and respect. A truly developed athlete knows their limits, respects their body, and values both competition and rest. So, key recommendations and future outlook. So, what we can do is to enhance the accessibility of, well, not just physiotherapy, but the healthcare support system that surrounds an athlete. We can enhance that in the rural areas. We can build national databases for youth athletic health. We can look at the holistic care that protects health and elevates performance. We can focus on simple high return habits such as warm-ups, strength, sleep, and load tracking. We can build sustainable systems in schools, clubs, and to build templates and routines to win. Now, final thought. Availability is the best ability. And a healthy athlete trains more, learn more, and performs better. Thank you.
Okay, thanks. Thank you, Mr. Thompson. And now we'll have pre-participation screening of athletes, and that will be done by Dr. Akshay Mansin. He's a senior lecturer and dean of the Faculty of Sport at the University of the West Indies, an orthopedic surgeon with a Master of Sports Medicine from the University of New South Wales in Australia. He also holds a Doctor of Medicine in Orthopedics and is a fellow of the American College of Surgeons. Dr. Mansin has served as Chief Medical Officer for the West Indies Cricket Board and as a member of the International Cricket Council Medical Advisory Committee. He's a respected leader in the Caribbean sports medicine. He's a respected leader in Caribbean sports medicine with decades of clinical and academic expertise in athlete care and performance. Just would like to make a correction there. He was the Dean of the Faculty of Sport, and we'll now like to invite Dr. Akshay Mansin to come up and share with us his presentation.
Thank you very much, and I'm cognizant that I'm the person between you and the end of this session, so I'll try and get through this very quickly. But when we're talking about the holistic development of the Jamaican athlete, I thought it was important to talk about pre-participation evaluation, simply because we've all heard from time to time that athletes go to the games of the highest level, and when they arrive there you hear that they're carrying an injury that was not detected, they cannot perform, they cannot be part of a team, which sometimes costs us very, very dearly. A country like Jamaica, which is a high performance sport, should have a holistic pre-participation system for all sports. Nonetheless, if we can get the slides up, please. What I'd like to just talk about is it this one here? No? Big one. Okay. So when we talk about pre-participation evaluation, it's really screening. And as Dr. Jones had mentioned before, screening is an efficient, cost-effective way of detecting conditions. So what you're talking about is a large number of athletes. It could be for a team, it could be for a nation, it could be for a club, but it's usually more than just one person, obviously. So you want to have an efficient way, which is cost-effective, yet able to detect conditions. One thing to point out, it's not 100% detection. So we're looking for certain things which may be specific to the sport, which may be life-threatening, but it's not going to pick up everything all the time. Nonetheless, it's something which allows us to screen, allows us to pick up the more likely things. It's not going to be pathognomonic, which means that you may pick up something, you're not going to get a diagnosis necessarily, but it's the start of then investigating further. Going forward? It may not be 100% accurate, meaning that you may pick up a problem in screening. The aim is not to then go and find out exactly what it is. It's to sideline the person and say we need further investigation, further examination. And it's not a way of eliminating athletes. And this is something that we try to get the athletes to understand from the start. We're not doing this to stop you from competing. In fact, in studies done across the pond, on both sides of the Atlantic, the not clearance rate is less than 2%, which means that 2% of athletes that you screen will not be cleared to participate. But up to 12% will be cleared with some provisos, and that's what we're going to talk about in a second. Also, what's very important is that in almost 80% of cases, this is usually the first contact between a medical personnel, especially a doctor, and an athlete, sometimes in life. And so it's very important that you can pick up things at this level for the first time. Now, the goals of a pre-participation evaluation, obviously, is to detect conditions that will predispose to injuries. The commonest thing that I see in athletes, for example, are tight hamstrings, which are going to cause hamstring strains if we don't deal with it early. And at an elite level, which is what we're talking about here, the tragedy is that our high school system is not geared at ensuring that these people move to the highest level of sport. It's geared to ensure that you get a medal for the high school, or you win the cup for the high school. And therefore, unfortunately, in development of the holistic development of elite athletes in Jamaica, I would say the majority of athletes are weeded out from before because they don't have pre-participation evaluations and they get injuries, and you spend years chasing behind that injury. The goal of the pre-participation evaluation is also to detect life-threatening injuries, most commonly cardiac injuries, but it's also to fulfill legal commitments, and we'll talk about that in a second. So as I mentioned, it's an entry point for medical care. It's a screen for life-threatening conditions. It allows you to review the history of the athlete and identify things that are going on, identify current illnesses, risk factors, and it goes on to identify factors that may affect performance. Now, you heard about a lot of these factors. They could be dietetic, they could be psychological, there could be other things, emotional, etc. But this allows you to have interaction with the person. It allows you to review what medications and, more importantly, what supplements they're taking with respect to the anti-doping requirements. It allows you to provide education advice about aspects of healthy and good performance. Then it provides medical clearance for participation, which means that whoever is engaging you to do it, be it a confederation, be it a National Olympic Committee and so on, you can then certify the person and develop a rapport between athletes and the sports medicine team, especially if the same people are going on tour or at a game with you. The pitfalls, however, are that it does not guarantee no injury or death. Let me repeat, we're trying to screen people, we're trying to reduce the risk, but it's not 100% guarantee that people will not get injured or may not even die. Happily, that's not very common. There is a cost, and for everything there's a cost, and unfortunately that's where shortcuts start being taken. But obviously, if you're going to do things, you got to do them properly. And usually that means that you need experts to do this thing, people versed in sports medicine. It also can lead to potential communication problems between the coach and the doctor unless everybody's on board. So it's important to have the coaches understand what you're doing. We're not trying to uneducate them on what you've taught them. We're not trying to rule them out of your competition. We're trying to help you in getting the best performance out of this person. And of course, this is not where somebody gets their annual checkup on a general basis. This is specifically for sports-specific problems. Now, there are many components to it. The screen generally involves a general screen, which is a general health checkup, a cardiovascular screen, and a musculoskeletal screen. But if you're doing it holistically, you will also have a nutritional screen, you'll have a psychological screen, etc., etc. But added to that will be sports-specific screens, because obviously somebody playing netball has different needs from a sprinter or from a tennis player. Age-specific screens, and also gender-specific. Usually, if you're looking at a holistic a year, then 6 weeks before the start of a season, you do the holistic screen and do it every year. But that can be affected by circumstances, such as, for example, if you look at the cricketing calendar right now, that's 24/7 almost. They're playing about 10 months, 11 months around the year, and therefore there's no defined season per se. But whenever they're going to do their test, you rest the night before, no caffeine at least 30 minutes before you're doing the testing, and then we get into what we're going to evaluate. Now, what I prefer is what I call the multi-station system, whereby each station is manned by a specialist, and it's flexible and it's staggered. So if I have a squad of 20 players, it's pointless calling all 20 of them to come into a hall to sit down and wait for 3 hours. That immediately erodes the trust between the system and the athlete, and it's going to lead to improper results. So, if you have 4 stations, call in 5 athletes. Let each one start at a station, but stagger it on a timely basis, and give them the responsibility of being on time. This concept that we have that everybody must come and wait is outdated by at least 50 years. It has to be adaptable. If one station is getting piled up, move them somewhere else, and move it around so that they can see who they have to see by the end of the whole procedure. Usually what we do is we start with a history, and that usually is a questionnaire. So everybody can do the questionnaire when they arrive. It doesn't mean everybody has to do them at the same time. When they arrive, they do the questionnaire. Typically there's a nursing station where they check various components that we'll talk about, and then they have, as I said, the general screen, orthopedic screens, or if you want to call it musculoskeletal screens, tests and certification. That questionnaire that I was talking about is easily available online. We have versions of it. But what you're looking at is past illnesses, allergies. That's very important because this is the only time that you're going to find something about their allergic history, unless you ask for it regularly. Family history. Immunization, which is very important if you're traveling especially. Medications and supplements, as I said. Not only that, but here is where you tie in that consent form so that you can disseminate information to relevant people, not the press, and they also can understand that they're giving you permission to do whatever. But I re-emphasize, it also gives you a chance of looking at previous injuries so that you can anticipate what's going to happen ahead. That nurses station that we spoke of is where they check the various parameters that you see there before they move on to a GP or a sports medicine specialist, a sports medicine doctor, who's going to do a sort of holistic check on the cranial nerves, ear, mouth, and nose, cardiovascular system, respiratory system, abdomen, etc. Make sure that the person is generally healthy. After that, there's a musculoskeletal check done by a sports physician or a sports physiotherapist, somebody who is versed with the musculoskeletal system, which is a head-to-toe approach. Doesn't matter if the person is just doing one, throws in a competition. You want to go from head to toe to make sure that all the parameters are working. It's done systematically. You're checking every joint. You're checking the muscle strength. You're checking endurance. You're checking all aspects of the musculoskeletal system. The physiotherapist may take it to another level, checking on their core, giving them general advice, specific advice on specific things that they may have in terms of tightness, weakness, and so on, and on things like stretches, etc. Now, when you're finished with that, there's a form that's filled out which talks about further appointments. Many organizations insist, as they should, that there's an annual blood test. That can be done at this point, and then you have to decide which tests you can afford, which tests can be done practically. And then, of course, the cardiac screen that I'll talk about in a bit. But having done that, we're now able to recommend or certify the person. And on that certificate, the front just says that this person is cleared or not cleared. But on the back, it can say things like not cleared for certain things or cleared for all sports. But more important, there's a thing there that says recommendations. And that's the most important thing. Because you may say that this person can go and play the whole season, but they need some strengthening of the hamstring, they need stretching of the hamstring, they need core stability, they need whatever. That can be stated there in writing. So now you've got somebody the athlete, who's put out a questionnaire stating every medication they're taking, every supplement they're taking, every allergy they have, and they've signed to it. So it's a legal fulfillment. So nobody can turn around and say, well, I was taking this and I told the doctor. If it's there, you told them. If it's not there, you didn't tell them. You also can't say, well, they didn't tell us about X, Y, Z. Everything is there in writing. But more importantly, this now can be passed on to the coaches, can be passed on to the organization, for them then to look at the recommendations and make sure that this person is absolutely optimal when it comes time to compete. I'm going to briefly mention the CVS screening, which is the heart screening basically, because sudden death you hear about, unfortunately, every year. It's not very common, but as you know, it's devastating. The problem is it's not always preventable. But in athletes, there's a 2.5 times more chance that you're going to have a sudden cardiac death, especially if you're older than 35 years of age. A lot of it is due to heart problems like cardiomyopathies. Some can be due to coronary artery problems. But the issue is that it's higher in the African population, or the derivatives thereof, Afro-Caribbean, Afro-American, etc., in footballers, in basketball players, and in males. So those are your higher risk, but it still means that everybody should be screened. Of course, the prevalence is only 0.3%, so it's not very high. But the tragedy is that only 3% of people who've had sudden cardiac death were identified in a pre-participation evaluation. So even though you've done your heart screen, you're going to pick up those who are obvious, but you're not going to pick up very many of them. But the truth is, if you can even prevent one death, you've done a big, big, big service to the person, obviously, and to the nation. Now, in Italy, they claim that once they did cardiac screening on all their athletes, there was a drop of almost 90% since they made the ECG mandatory. That's not really the same for all other countries, but the reality is that it's still recommended that one does an ECG, even though it doesn't pick up most conditions. Why? Because it's the cheapest, unfortunately, the cheapest and most available way of doing a cardiac screen. Many organizations like FIFA insist that if you're going to play any FIFA competition, you must have an echocardiogram, which is far better because it shows you the structure of the heart. But not everybody can get an echocardiogram, especially if you're dealing with schools and so on. And some countries don't even have it around the globe. So some places will insist on it, and then you have to make make it available. But clearly, the echocardiogram is the gold standard, but not easily available, and therefore the ECG is what is recommended. It prevents about two lives per 1,000 athletes, which is very good, because those are two. If you're one of those two, then obviously it makes a big difference. And even though ECGs cost about $90 by and large on average, we heard earlier today where that service is actually free for Jamaican athletes through the Jamaica Sports Medicine Association. And therefore, the fact that we're not taking that on really is an indictment on all of us, really, meaning from the sporting fraternity. Now, clearly there has to be sport-specific screening, whereas I can carry some sports people with a broken finger. For example, I could take a sprinter into any game with a broken finger. It's not recommended that a boxer has a loose tooth or has broken fingers. So for a boxer, a dental screen and obviously looking for their fingers and so on in detail is very important. As I said, you can accept some injuries in cricket that you can't accept in athletics. One thing you learn in athletics is that if it comes to the muscles of the lower body, there's a 0% acceptance because that's going to go on to greater problems in the future. To know which injuries to look out for, you have to know which one to anticipate. And I love putting up this path. You're going to remember this screen because this was the cover of the directory for which had our Sunshine Girls on it. And this picture does not show a single knee. This path, you'll tell them why, because between you and I, we'd operated on each one of them. At that time, we had an epidemic of knee injuries amongst our netballers. Having identified it and changed the program of training and so on, we'd cut that down to almost zero in the next few years. But at that time, it was an epidemic, which through screening and intervention, we're able to prevent. Now, I'm going to spend the last 5 minutes talking about fitness training. And I'm going to talk about fitness training because to me, that's part of the pre-participation screen. Fitness, as you know, has many components, and they're all listed there. And each one has a specific test. The tests that I'm mentioning are not the only tests, but are the ones that we use, for example. So if you're checking flexibility, we look at the upper body and lower body flexibility tests, like sit and reach. If you're looking at lower body power, you can use vertical jump, medicine ball throws for upper body power, planks and push-up to assess the core, anaerobic 40-meter sprints, agility, you can use a 505 or anything that has deviations in the running pattern. Beep tests and 4-kilometer runs for aerobic and endurance tests. Now, as I said, these are not the only ones, but in our battery, this is what we tend to use. And when we do this, it's done over a 2-day course usually, where, are you going to be able to click that for me, please? We're just going through the components. One station where somebody's checking on their flexibility, there's another station where they're checking on plank and push-ups, and checking on their core, and you're checking, everybody's looking at them individually. You're looking on one-legged squats, agility tests that I mentioned before. You can do endurance tests indoor, like the beep test or the yo-yo test, whichever you prefer to do. And all of these are done, then the next day we'll take them out and do the sprint tests, and then that'll be followed probably by the 10-kilometer, the 10-lap run, which is the 4-kilometer. It's just somebody who pretended that they were somebody very famous. But the point is that at the end of that, you've got a holistic test. So they've done their 10 laps there. Now, obviously, this has to be made specific to who it is. This being a track club, it's pointless putting the sprinters through the 10-lap test. We're not really too interested in their aerobic strength, so we might modify that. It's pointless taking a 100-meter sprinter and putting them through an agility test. But it's very important to make sure that their flexibility is good. So when we finish that testing, we can then plot the results. And I'm giving you an example here of the individual who's in blue, plotted against, and on the orange, you can either have minimum standards, or you can have the mean of that cohort, or whatever it is. So if you look at this sprinter, for example, at the top was BMI. The BMI was a bit lower than the average. The next one is percentage body fat. That too was a bit lower than the average. Next one is the upper body, and then the upper body right and upper body left flexibility, followed by sit and reach. Upper body was less flexible than lower body. Vertical jump was slightly less than the average. The medicine ball throw overhead was above average. Plank was above average. Push-ups below average. Aerobic very low. Agility okay. Beep test not bad. Now for a sprinter, we have issues here because the upper body is not very flexible. So when they're driving while sprinting, they can actually gain a lot more by getting more flexibility. Is that something they'd have looked at? Probably not. They'd be running intervals constantly. The core is pretty stable, even though the push-up could be improved. But the anaerobic test, the 40-meter sprint, is less than normal. It's less than the average or less than what the minimum standard is. So we can now go to the coaches and say, this is what we need to focus on. As opposed to this middle distance runner, who once again, you can work it out with me. The BMI and the percentage fat on the top is low. The person is not of average build. Now the coach can decide whether that's what they want or not, but we can provide them the empirical data. The upper body flexibility on the right side is not very good, but by and large the person is pretty flexible. Power is not bad, but once again their anaerobic work could be worked on, can be worked on. The 4-kilometer run and the beep test, well 4 kilometers is well below average, but for middle distance runner that's not good. So maybe what we need to concentrate is more their aerobic and anaerobic capacities and not so much on gym work because they're pretty well average there. And just two more to look at. This person is a shot putter. Shot putter with a sort of average body fat, low BMI, low flexibility in the upper limbs, good lower body power and flexibility, weak push-ups, weak anaerobic, and sort of weak endurance, 4-kilometer run. Put it back together. Does the shot putter need anaerobic strength? Not to the extent of a 40-meter sprint. So I'm not too worried about that. For this person, what I'm really interested in is the upper body flexibility. If you're a shot putter, you obviously are very muscular up here, but if you're not flexible, you're going to lose out on some of that spring. And the last one, a world-class discus thrower, I think this was. Is that the same one as this one? Yeah. A world-class discus thrower who, as you can imagine, body weight, BMI, and percentage fat is high. That's very good. We want that. Upper body flexibility, excellent. We want that. Sorry, sit and reach, which is lower body flexibility, very weak. Vertical jump, very good. Good power in the lower limb. But the plank is abysmal. Now those two things, the flexibility of the lower limb and the core, if they're weak or not up to standard, that is going to affect your throw. So that is something we're going to spend time on. The 505, the beep test, I really don't care too much about. That is what we're going to focus on. So we can go to the coach now and say, this is the program we're going to work on for the next year, and then test them again if we have to make sure that they're catching up with what they have to do. So just to summarize, the pre-participation evaluation has to be relevant. It has to be cost-effective, but not zero. And screening must be understood by all, the athlete, the coach, but more importantly, the people who are conducting it. Because in the end, what we're trying to do is to help the person to participate, not to prevent them from participating. Thank you very much.
Okay, thank you, Dr. Manson. At this moment, we're going to be having the questions and answers. So I'm just asking Mr. Alex Johnson, Mr. Desmond Thompson, and Dr. Manson to please come up on the stage. Okay, so this is the questions and answers segment. We'll be only taking about 10 minutes here in this segment. Does anyone have any questions they'd like to ask our panelists?
Hi, this question is directed to Mr. Alex Johnson. Regarding your slide on the protein shakes and the protein building, it's a myth that it builds protein in correct me if I'm wrong, that one in a short space of time or whatever. But I saw some time ago a celebrity trainer that was trying to increase size in one of the popular actors for a role under like 6 weeks, and he said that how he got this actor to be really bulky for the role is that he gave this actor a lot of protein shakes, and that's how he got him bulked up faster. So is it that the protein is this responsible for that, or are you saying that they're taking enhancement supplements to achieve that?
Okay, good point, good question. So they would definitely have to take some form of enhancement. So that supplement may have something additional in it. Protein is necessary for growth and development, but excessive proteins amount don't give you any vast changes or differences in especially such a short space of time. And if you're not doing physical activity with that protein intake, you won't see much changes in terms of muscle growth and development. But they have been promoting more protein, more protein, more protein. And when you check it out, some of these trainers are connected to the protein supplement distributors. So many of it is business-wise, why you hear them promoting it like that.
Okay. And my other question is for Dr. Mang Singh. By chance, is there any reason why sudden cardiac death is more popular in the male footballers and basketballers when compared to the track and field athletes?
Yeah, I don't know if popular is the right word, but it's more prevalent.
More common.
Yeah, well, listen, there might be 2 or 3 things. If you look at the racial profile of those athletes, you've got a lot more of African descent in it as well. So these studies, which are done primarily in North America, have that bias to it already. Secondly, what wasn't present in that study, which I'll bring out immediately, is the use of supplements and what they might have been doing to put excess pressure on the body. But nonetheless, excessive work, improper lifestyle, abuses, etc., lack of proper diet and so on have all added to that, and those are 2 populations which at the professional level have it very high. At a high school level, unfortunately, a lot of people come from a lower socioeconomic class in those sports. And that then is affected the other way around, which is poor nutrition, poor awareness, poor medical facilities. And that would probably lead towards the skewing in those 2 sports.
Okay, thank you.
Are there any other questions?
First question is for Dr. Alex. Probiotics and yogurt you mentioned. A lot of athletes will not be able to afford $200 plus, $300 plus yogurt. Is there any value in papaya, or are there any other foods that's good or you'd recommend for gut health?
Okay, so in terms of our probiotics, it's usually fermented products that they have that, become probiotics, the bacterial growth. Now, with probiotics, there's no real fruit, like natural fruit or vegetable where you can get probiotics from. So we usually recommend the yogurt. but there is probiotic supplements where, yes, it is more expensive for a whole bottle, but if you work it out, it's cheaper, you know, because they would have maybe 100 tablets for that can last them for 100 days versus one container of yogurt. And the 200 plus is not the cost for real yogurt. Real yogurt, you're looking at 500 up. For, yeah, we have to be real, you know, real yogurt is expensive, especially when it has live culture in it. So it's an investment that I think we have to think about. But the probiotic tablets are another way you can get it. There's not much research though on natural fruits and vegetables. I don't know if you guys know any that could help support me. Yeah, so Doc will add, to my colleagues will add to that. But I don't know any other sources currently, but it's something that I can research and get back to you on.
Thank you.
Yogurt can actually be one of the cheapest probiotics because if you have culture, you can actually make it yourself and keep it going constantly. So it actually is not very expensive at all. You just have to put in the effort.
Well, we need to get the word out there and educate our junior as well as elite athletes. A question or a comment on Dr. Mansing's presentation. So PHEs, as it relates to the JASM, we have that ongoing offer to our junior athletes. But what do you think, or how does behavior, how do you find behavior in both athletes, coaches, and some team managers affect the conduction of PHEs then, other than those teams that it's mandated by a federation or a higher body? What has been your findings or with that?
Thanks for that, Pierre. And I'm going to actually join that with the question that we just got online. So let me just hear that one first.
Okay, so the question online is, how many of our athletes engage in doing this level of preparation testing? That's for Dr. Akshay Mansin.
Just to combine the two, you're absolutely correct that unless it's mandated, not all coaches will follow a proper pre-participation screen. But let's just break it down. To answer the question about how many of our athletes do follow this. So let's start with Jamaica Cricket Association. Anybody who's representing Jamaica at any gender, at any age group of cricket, undergoes a full screen, which includes the annual full medical with blood tests, ECG done every 2 years, and a proper screen done before every competition. So I know that cricket is fully covered. I know that in football, I'm not talking about the national football team, I'm talking about at Premier League and below, it's mandated that they must have a pre-participation screen, however not mandated by whom. And therefore, there are two sides to it. One is that some do get screened by who I'd call qualified or versed in sports medicine. Others get screened by people who are not versed in sports medicine, but get the certificate signed. And I've been approached by clubs in the past who have come to me and asked me to sign the certificates, and they'll send their players later to be tested. So I can imagine that when I refused, they went to somebody who would probably oblige. So the question there is, that is where we've failed in convincing the coaches and the organizations that this is something good. Going down to athletics, there are some major athletic clubs that do a full screen, and there's some major athletic clubs that don't. But when we go to massive games, from Olympics down to World Championships and so on, I can't tell you that there's a proper system in place. I'm not saying they don't get screened, but I can't think of a proper system in which they're certified and so on, which is one of the tragedies we had. Nonetheless, it's much better than how it used to be. So just to try and summarize it, I think when they're mandated, most try to get it done properly. Once it's at a lower than national level, they try to get around it in whichever way they can. But cost used to be an issue until President of Jamaica Sports Medicine Association, Rhonda Hudson, came on the news, was it last week, and talked about how many people are not taking on the free service, and therefore cost can no longer be the issue. So to answer you, I don't think it's as good as it should be. I think it should be mandated, and if you can't find somebody to do, then we can tell them where to go. But I believe it needs to be mandated, and then it needs to be certified to ensure that it's been done by the right person. When it's the right person, qualified people.
Okay, thank you. I can only take one more question. 5 minutes left, and one more question for. Is there a question for Mr. Desmond Thompson? All right, Dr. Manson have to leave shortly. We'll have another question. Go ahead.
So, Dr. Mansingh, I noticed that in some of the gyms, there's not much of a pre-participation screening. And I've witnessed a couple persons or gym goers being injured or have underlying conditions. Like I have witnessed an asthma attack as a client there at a particular gym. And the trainers are helter-skeltering. They're not certified in first aid. So, how can we advocate to have more gym goers being, participating in screening, or advocate for the gyms to have that in place for the clients?
Well, you said the first thing right, which a lot of gyms don't have certified trainers. I think most certified trainers would be able to do a pre-participation screen for a gym program, which would be different from an elite athlete going to a gym. So the answer is obviously if they have too many problems like this, then there needs to be some sort of certification, and that is a policy issue. And that policy issue has to be taken on by ministries of health and possibly the ministries of sport in collaboration with organizations like the Sports Medicine Association to ensure that there's some sort of, when I'm saying there has to be certification, it's not about being punitive. It's about providing education. So what we have to do is ensure that that's kept on the front burner, and conferences like this promote people outside of the health fraternity coming in and learning about it.
Because another thing is that some are certified and they're not putting their certification into practice. And another thing is when these things are promoted, they're not showing up.
So to me, it's a marketing thing. If you are certified and you have certified people, put that on your billboard.
Okay, thank you.
Okay, thank you. Are there any other questions online? We can take one more from an online. Okay. Okay, thank you. We thank you, Mr. Alex Johnson, Mr. Desmond Thompson, and Dr. Akshay Manson. We really appreciate your presentations. All right, so at this moment, we're going to have the simulation exercise, and followed by closing activities. We'll be having, there are some cases, and I want every person to gather around this bed. So this is based off of everything that we had learned from before. We're just going to put everything into practice and see how well you can apply what we have learned. So here with this case, we have Mr. Derek Laylor, and he's a 23-year-old junior national powerlifter. He has a history of asthma and ADHD. He is inconsistent with his medications, experiencing periods when he takes them regularly and other times when he does not. His asthma attacks occur sporadically. While in university, he began using marijuana, claiming that it has helped ease his breathing symptoms. His current situation: during a training session today, Derek was pushing himself intensely while attempting a deadlift. He heard a loud pop sound and immediately lost his balance. He was rushed to the hospital. His next international competition is in 3 weeks, and he's very concerned about missing it. Based off of what we had learned earlier, how would you approach the situation? Okay, we'll take one person at a time.
I was asking where was the pop? Where was it coming from? or the pain?
Okay, so the pop or the pain, the pop came from the knees.
Okay.
Both knees.
And what kind of athlete is he again? Sorry.
He's a power lifter. And just to make the difference, oftentimes when we see on the flyers or in certain pictures, we see someone doing a snatch, a clean and press, a clean jerk. Those movements, those exercise or that type of sport is weightlifting, Olympic weightlifting sport, and it involves more power. Power which involves speed and strength, whereas power lifting involves 3 lifts. You have the squat, the back squat, deadlift, and bench press. And that's more involving of strength, maximal strength, and it doesn't involve speed any at all. As long as you can make that lift successfully with proper form and technique, that is powerlifting. So that's the difference between the two.
All right, so if I may ask as well, when did it pop occur? Was it during your squat exercise, during your workout?
During his training session, he was pushing himself a lot intensely, and then
Alright.
that's when he heard the pop in both knees.
Which part of the training? Was it warm up, in the middle of training, towards the end?
Well, he was doing a deadlift. He was performing a deadlift.
The deadlift, okay. I heard a pop in the knees, all right.
And after hearing the pop, he lost his balance.
Ah.
And he had to be rushed to the hospital.
Right, so to clarify, so the deadlift exercise is the one where the weight is on the ground, and you pick it up, and you just bring it to, no, you don't pick it up here. That's not the weight, that's not the deadlift. Right, no, you bend your knees, and then you just stop with the weight this way. So you don't carry it overhead. So that's the deadlift, for clarity. Understood. All right. So the front, was it the front of the knees? Was it inside the knee? The pop? Or was it swelling afterwards?
In both knees.
Both knees.
All right, so what I would want to also find out is the medical assessment. How would you carry out the medical assessment? Any differential diagnosis? Is there any imaging that you'd want to perform?
Okay. So he has no swelling either, or does he have any scars, or?
So you'll be looking for scars, you'll be looking for swelling. Is there anything else that you'd want to assess for?
Previous injuries, of course.
Previous injuries, okay.
His technique.
And technique, all right. Is there anything else that you'd want to perform? He had heard the pop in both knees, lost his balance, and then subsequently after that, immediately after, he had to be rushed to the hospital.
Why? Yeah. Was it that he lost consciousness afterwards? Why?
No loss of consciousness.
Was he able to walk after, or lost balance?
Okay, so what we'd want to do medically, asthmatic. He's asthmatic and has ADHD. Inconsistently taken, he's not, and he smokes marijuana. And a national athlete. So a few things I figured that you'd want to do is get the history of his asthma, the situation pertaining to his asthma and ADHD, his medical adherence, his medication adherence, and the effects of these medications that on him, and the incident assessment. That's when I figure you'll be looking more at, in terms of the swelling, where's the swelling, if it's gross swelling or if it's more compartmentalized, or if it's localized rather, range of motion, and you do your special tests, all the special tests regarding the knee, to rule out or rule in if there is any ligamentous injury or if there is any meniscal injury. Right, and the weight bearing. And you'd also, I think, if you are interested, what type of diagnostic imaging would you want to perform first? Depends on the examination, depends on the test. Some persons may want to do x-ray first just to make sure that
I can do a quick
fine.
ultrasound of the knees.
Ultrasound, the knees. As it relates to the physiotherapy assessment quickly, what would you want to do physiotherapy-wise?
I was hearing check his quads for possible.
You do a musculoskeletal assessment.
Musculoskeletal assessment, yeah, man.
Right.
Rule out things like a quads tendon rupture, patellar tendon rupture, stuff like that. So I can even move the leg, that kind of thing.
Okay, all right, fine.
But that's it. So was he able to stand up afterwards? He said to be rushed to the hospital.
Right, he fell.
Right, so he's not able to stand up in
He was unable to stand up. Weight bearer, he had to be rushed to the hospital.
Okay.
And I figure you probably would want to consider doing a functional assessment if possible, if you can, but because the person is unable to stand and had to be rushed to the hospital, that part would have to come in later on.
But then we're assuming that his cognitive function is intact. Is he able to speak and other stuff?
Okay, good. Yeah? You'd have to assess for that as well.
Yeah, so like a mini mental test, that kind of thing.
Right. Thank you. Okay, thank you very much, everyone.
What's that?
Okay, good question. What do you think would be the differential diagnosis? I would like the top three differential diagnosis based off of what you had just heard.
Yeah, it could be a tendon tear, tendon injury, rectus femoris or quads.
It could be a muscle strain.
Right.
Or a tendon strain.
Right. That's number one. Someone said that was
I don't think I have enough information to give you 3 diagnoses, but what I'll tell you, first you think about something outside of the knee. So it could be the quadriceps, patellar tendon, involution of the tibial tuberosity. Think of something in the knee, so it could be any of the ligaments. Or you think of something generally, it could have been something in his head, it could have been something to do with dehydration.
So I can just mention a stroke right here as well. Could be a stroke. Yeah, there you go. Very holistic approach there, I would say.
Thank you. At this moment, we're going to be changing gears and be going into that was it.
Look like it's well now.
Okay, so the actual diagnosis of this case is the quadriceps tendon. So for those of you who had guessed the right one, very good. And good job to everyone else who had gone in with the assessment and you have done your various assessments.
Ladies and gentlemen, Dr. Mansingh has to go, so we're going to give the presentations now, but I encourage you to stay 2 more minutes. There's one more simulation exercise that I would love to hear how you handle it.
Good afternoon, everyone. You heard me first, and I'm just calling the day on my duty now. On behalf of the National Powerlifting Association of Jamaica and the Faculty of Sports, UWI, would like to make a special presentation to Dr. Mansingh. I know that today was not the greatest day for him, but he have found his way here to ensure this conference is a success. Thank you again, Mr. Mansingh. It's subsequently boots him up tonight. And then the wine just tip it off. Yes, man. When we give a lot. Okay, thank you, man. Next we have Mr. What's his name again? Mr. Johnson. Mr. Johnson did a very good job today in terms of teaching us to make our health. He's the man, you call him the health man. He's the one that is going to help us to eat properly. So, Mr. Johnson, on behalf of the National Powerlifting Association of Jamaica and UWI, would like to make this simple token to you, sir, for your appreciation of the wealth of knowledge you gave today on behalf of yourself. Thank you very much, sir. Again, we're going to boost him up with supplement and the wine. And last of all, not my favorite, but he's my friend. We have been at it for some time now. I call on you. And also a member of the NPAJ, Mr. Desmond Thompson. Give him a round of applause, man. He's not my favorite, you know. But he did a good job today.
You can put title to my name. It's the two-time national 120 plus powerlifting champion. Currently the national holder of the squat of the deadlift record.
Champion, there we go.
And previous three-time record holder of the bench, squat, and deadlift.
As the president, I'm going to put them on a review. Mr. Desmond, I do appreciate you very much for what you have done today. He has break the rank from an athlete now to a presenter. So next thing, I want to hear that he's the next president. Thank you very much, sir. Okay, I would like to just say another thing. We also have some member of NPAJ in the house. We have Mr. Diallo. He's also a member of the medical committee and the former chairman. Diallo, come this way. Let them see her. This is Diallo. He's also a member of the medical committee and an NPAJ member. Right, this is Diallo. Diallo, you did a very good job today, and I must say we do appreciate it. Give him a round of applause. Right. Huh? I know. And last of all, I would like to call Mr. Ramon Hunter. Mr. Ramon is one of the members who started off with the NPAJ in 2020. He was a former chairman of the medical committee. Now he's a presenter. He's everything you can think of. He has set the trend in terms of the medical committee at the NPAJ. Ramon, thank you very much again. All right, so I'm just going to let continue with the last unit that you guys have. So thank you very again.
All right, so we have one more simulation quickly, and then we wrap it up.
So, thank you for staying. The last simulation exercise. We have a young footballer, a 19-year-old male footballer who presents to your sports medicine center. He admits to having a poor diet by choice. He avoids fruits and vegetables and consumes fast food at least 3 to 4 times per week. He also reports smoking marijuana about 3 times per week. His BMI is borderline undernourished, so he's about 18.45. And his current situation, he has been complaining of abdominal cramps and fatigue. His coach has observed that he has been running slower on the field. He has not trained for the past 4 days due to this discomfort. During your assessment, you also learned that he just found out his 17-year-old girlfriend is pregnant. How would you manage this young man? Anybody? Remember, we're looking at the holistic picture. We're looking at everything that is going to affect him and his performance as a footballer. Anybody? How old is he? He's 19. How old is his girlfriend? Legal? Is that legal? What is the age of consent in Jamaica? So it is legal. But she's 17. She's just finishing school or not quite finished with school. So there are social issues around that. As a footballer, he's just 19. He's trying to build his career, and therefore he needs to start thinking about building his career with a wife, potential spouse, and a baby. Just leave school. The short answer is yes. And this is a very typical situation, not necessarily the pregnancy, but this is a typical situation. What other social issues would you zoom into immediately? Nutrition. What about his nutrition? Who said that? Yes. That is correct. That's right.
Marijuana and the empty stomach.
That's right.
Marijuana might have its problems depending on who the person is, 'cause it doesn't trouble everybody. But if him not eating the marijuana, certainly going to mash up the stomach, if not the head.
That's right. Anything else? Yes. As a footballer, as a footballer, so what he gets is like a stipend.
Okay.
Anything else you want to put into the mix?
He needs to see a psychologist. He needs whatever
Expand.
issues that is going on, why he's eating poorly, plus the stress of his pregnant girlfriend, and then he's not probably earning much. So that's gonna play a role in deciding, okay, what kind of goals he wants going forward. And with the stomach pain now, after he needs to sort out the stomach pain because all these issues are causing possibly an ulcer to develop. So everything interrelated, his social issues, his mental health issues, and he will have a direct impact on his health.
Okay, so he needs a psychologist. Does he need anybody else in his team?
A nutritionist, dietitian.
Anybody else?
His medical doctor.
Medical doctor. Why?
To assess why he's having that stomach pain, rule out any other causes.
Anything else that you can think of?
A social worker, maybe assess the situation.
All right. Okay. All right. Well, I will stop it there. The list will go on. But yes, all of that is very important because even as a footballer, very happy to get the little football work and thing, but then his world around him is crumbling and he needs assessment and he needs help. So sometimes when we get these young athletes, we're proud of them, but we have to remember that they have a life outside of the field, whatever the field is. This particular case, what we were shooting for is constipation, which is not something that is unnatural. He's not eating properly. He's having abdominal pain. He's moving slower, sluggish, whatever. So he probably just wants a good bowel motion, right? Okay, so thank you very much for that. Finally, I will ask you to just sit for a few more seconds to allow me to go through my thank you list. It is extensive. A lot of people are here to thank. I first want to thank Father Brown of the Stella Maris Church. He arranged the venue for us and he has given us countless discounts. It is shameless. But I want to thank Father Brown. Miss Sharon Nita, who is like a secretary to the church, she also has been very instrumental in helping us put together a lot of the things that we needed today. I know it's no AC, but the ventilation was adequate and I trust everybody was reasonably comfortable. Miss Denisha Stewart. Yes, please give her a round of applause. She is the soup maker and the server. So I hope you enjoyed the soup, those of you who were able to have it. I want to thank all our presenters. They were absolutely magnificent. Their information was wonderful. Please give them a round of applause. I will just remind you, Dr. Bateman, he's a sports psychologist. Yannick Dunn, she works with JADCO. Pierre-Ann Brown, kinesiologist and physiotherapist. Dr. Kevin Jones, orthopedic surgeon. We had Dr. Mansing, we had Mr. Desmond Thompson, we had Mr. Alex Johnson. So we had a full gamut of persons with different disciplines within the medical fraternity. We also had our two presenters, our two dentists, Dr. Burke and Dr. Bryan. Thank you. I think my moderators deserve a special round of applause. Thank you so much. I'd also like to thank the security team, Mr. Fong and 3 of his security guards. I'd like to thank the IT team, that's AV Concepts. Whatever challenges were communicated to us, we went to them and immediately they did whatever tweaking they needed to do and persons reported back that the service was better. So thank you for that. Of course, we could not have gone through all of this without the sponsors, those who gave cash and those who gave kind. Our number one sponsor being Suppligen. Then we had Indus Pharma, who gave you that bag of goodies. So thank you to them. We also had the Sports Development Foundation, who was also one of our contributing sponsors. Medi Wellness Connect, that's a doctor's office. Mrs. Lauren DeMacardo and Mr. Rev. Cavone Willis also helped us in kind. Our conference secretariat, the director, Miss Brittany Haid. Miss Haid, can you stand for me, please? This lady has been working tirelessly for the past 6 weeks to help with the communications, and whatever little challenges there were, she was there ready and willing to fix it. So thank you. And the organizer, overall organizer, was Dr. Cheryl Burke. I think some of you may know her. I also want to especially thank our president and our NPAJ team, Mr. Michael Blair. He has been our unfailing support. Whenever we said we wanted to do this, he said, all right, let's go. So thank you, Mr. Blair. Our IT support, Alex. Alex, I don't know your last name, and I'm really so sorry. Thank you. And there was Ricardo, who helped us with our beautiful banner today. I don't know if I have left anybody out, because I've called almost all the people I interacted with, and I just want to tell you that I really appreciate all and everything that you have done for us. And last but not least, all our persons online, or persons who made it face-to-face, we thank you so much for coming. We hope that it was a very good conference for you, that you went away with some new information and did a little bit of networking. So we are really very happy that you were able to make it, and we want to tell you thank you so much, and we know we can depend on you for whenever next we do something like this. So thank you, everybody, and our conference is officially over. Yes. Say that again. Oh, yes, 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 yes. In the persons who are coming, our participants, we have a team here from Montego Bay. Are you going back tonight? Oh, okay. I'm thankful for that, because the roads are treacherous any time of day. So tomorrow is a public holiday. Enjoy your rest, take your time and go down. And thank you so much for coming, everybody. Good night.